Alita Juliet, the MCs for today's conference, take immense pleasure in welcoming all the delegates to the web conference on temporomandibular derangement, organized by the Association of Oral and Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch. I am sure that it is going to be a very informative session, and we have an array of presentations covering all the aspects of temporomandibular derangement and its management by eminent speakers from across the globe, followed by a panel discussion. And for the kind information of the participants, the conference is being recorded. With the blessings of the Almighty, let's begin with the web conference. Over to Dr. Mrinalini.
Good afternoon, one and all. Thank you, Dr. Melita. Now, to commence our program, we welcome Dr. Suresh Kumar to give us an introduction about the web conference. Dr. Suresh started off as an academician in the Department of Oral and Maxillofacial Surgery, Tamil Nadu GDC, as an assistant professor, and then worked at SRM Katangulathur. He is currently a full-time private practitioner. His areas of interest include orthodontic surgery, TMJ, as well as trauma. He has been a staunch contributor towards successful conduct of AUMSI Tamil Nadu and Puducherry branch webinars over the past 3 months. Over to you, sir.
Thanks, Dr. Mrinalini. So, yeah, very good evening to all of you. I could see a lot of senior practitioners who have come in already. So it gives me a lot of pleasure to be with you on this Sunday to discuss something on TMDs. So, if I'm permitted to share my screen, Dr. Jimsa.
Yes, Suresh.
Okay. I hope you can see my PowerPoint.
Yeah.
Yes. Okay. So once again, I welcome all of you for this TMD Web Conference on August 30th. It's going to be a very significant day because there are going to be very good experienced speakers on this particular field. So why are we discussing about temporomandibular joint disorders today? So, you know, it's not very rare as we think. It has got a very high incidence. Even in America, there are almost 10 million Americans who are suffering from TMDs. And it's the most complex problem in maxillofacial area. It doesn't involve only one structure. It involves the joint, the muscles, ligaments, and so on. And it's difficult to treat also. If we don't realize what is the situation of the patient, then it's very difficult to cure or control the disease. And it's recurrence prone. Once you have treated, he has become all right. It doesn't mean he's permanently all right. He can come back to you with the same problem. So it has got a lot of dilemmas, right? From diagnosis till the treatment. If you take the diagnosis, first we have to know whether it's a TMJ problem or something else. That starts with that. And then if the joint is the only one affected or it has already spread to the neighboring structures like musculature. And why is there an ear block for the patient starting from TMJ? And why does the patient have headache? And why does it spread to the shoulders and to the neck? So what is the relation? So there are so many dilemma and questions to be asked when you do the diagnosis. Of course, we have a good staging system for the TMJ internal derangement. But still, Wilkie's classification is very good, but there is a lot of overlapping between the stages. And so a clear-cut staging may not be possible. So we still are in a dilemma. And TMJ patients, TMJ disorders, when you start giving analgesics, the moment you give, they come back to you with complaint of drowsiness, somebody with nausea, and the pain recurs immediately after the action of the tablet is over. So these are the complaints normally what we see after giving analgesics. Yes, we send them to the physiotherapy, but again, there is a confusion there whether to use an interferential therapy or short wave diathermy or ultrasound or low-level laser therapy. There are so many options in physiotherapy also, which we are not very familiar. The physiotherapist has to decide, but we have to support them, discuss with them. And conservatively, when I want to treat the patient with splint, so I need to decide whether I'm going to give a maxillary splint or a mandibular splint, or I'm going to give a hard splint or a soft splint. And is it going to be a smooth splint or is it going to be is it going to be having indentations from the opposing side teeth? So is it a partial splint or a full arch splint? Or I'm going to tell the patient to use it for the full time, 24 hours, or is it going to be a night wear only? And how long? It's 2 weeks, 4 weeks, 6 weeks, 8 weeks. We don't know. A lot of questions involved in treating TMJ patients. And also conservatively or semi-invasive procedures, like the patients might require a Botox injections, myotomies, along with the other conservative treatments, which you need to decide. And arthrocentesis, it comes in between the conservative and radical treatments. To do a successful arthrocentesis, we need to know the indications and the type of solution you're going to use for your lavage, and how much is the solution, quantity of the solution to be used. And it is a technique sensitive procedure. If you don't put 2 needles exactly inside the upper joint cavity, we are not going to get the fluid out. And arthroscopy is an excellent tool. Right now, it's getting more popular. There are good surgeons, arthroscopic surgeons for TMJ problems. Again, if you want to use arthroscopy, then you need a good knowledge about it. But there is a longer learning curve, I believe, in using arthroscopies. And then there is a significant cost involved using arthroscopes. And if you want to really perform level 2 and level 3 arthroscopic procedures, you really need more trainings. And finally comes when my treatment fails with the conservative modes, we need to jump into the open joint procedures. We can do discopexy, discotomy, discectomy, arthrotomy, or even total joint replacement. So the options are many. So based on the stage of the patient, we need to decide what. So because we have a lot of controversies, there is no consensus even today for these TMJ problems, disorders. So the TN and Pondi chapter of AOMSI has decided to conduct a webinar, a web conference on this topic so that we can throw more light. And the association has been very careful to choose the speakers. And there are national speakers as well as international speakers who are all expertised in this field. So very carefully chosen speakers. And another advantage here is we have people from other specialities. For example, if you take Mr. Sanjay Pinto, he's an advocate. So he's going to discuss about the legal problems, what we can face in treating TMJ problems. And Dr. Chetan Hegde, he's a prosthodontist. He's going to tell us about splints, which is always a confusion for the surgeons. What splint to use, how long to use, how to make a splint, all those things will be explained. So with this, I'm sure we are going to enjoy a great session today on TMDs. So I'm requesting all the speakers to be attentive and to take some take-home points from the webinars. Thank you very much. Thank you. Handing over to Dr. Mrinalini. Thank you.
Thank you, Suresh sir, for explaining the different challenging aspects of TMDs in a nutshell and the need for addressing the topic in detail. Thank you, sir. And now I take immense pleasure in inviting Dr. Reena John, President, AOMSI, Tamil Nadu and Puducherry branch. She is also the head of the Department of Oral and Maxillofacial Surgery and Vice Principal Research at Vinayaka Missions, Sankaracharya Dental College and Hospital, Salem. She is my personal favorite and is an inspiration to many aspiring young surgeons. I invite you, ma'am, to deliver the welcome address.
Thank you, Dr. Melita, for those kind words. Greetings from the Association of Oral and Maxillofacial Surgeons of India, Tamil Nadu and Pondicherry chapter. It is indeed my pleasure to welcome one and all to this unique initiative of our association, Tamil Nadu Pondicherry chapter. On behalf of the TNA AOMSI and Stryker, I welcome each one of you to this TMD Web Conference. This is unique indeed. Thanks to all the overwhelming support that we receive from every one of you, that we have made baby steps from small initiatives like MaxFax Talk, Ask Your Mentor, and then going on to webinars ranging from topics from maxillofacial trauma to orthognathic surgery to secondary deformity corrections, and then coming to this concept called a web conference, which is possible because of the great support and the overwhelming support that we have received from each one of you. So indeed, we have a fantastic 3 to 4 hours ahead of us, where we are going to listen to the panelists who are going to talk to us from their experience. And what is unique about this topic has been spoken to us so well by Dr. Suresh Kumar. And our panelists are both international, national speakers, moderated by our state maxillofacial surgeons. The uniqueness of this panelists is that we have gone across specialities, gone across countries, and also have included reputed people from the civilian and from our Indian Armed Force. So looking forward to a great session with every one of you, and looking forward to a great learning experience. Welcome each one of you. Thank you. Dr. Jimson.
Thank you, Reena ma'am, for your words and for letting everybody know how we have progressed. I now kindly request the participants to post your questions in the Q&A section, and all your questions will be addressed during the panel discussion. Participants, kindly make note. Please fill in the feedback form to receive your e-certificates. The link for the feedback form will be posted in the chat box at the end of the session. So now let's move on to the scientific program. I know all of you are waiting for it. So over to Dr. Mrinaldi.
Attention, you all present. We now move on to the scientific session, which is preceded by 8 national as well as 2 international faculties. Buckle up as we hustle through this exciting scientific ride over the next 3 hours, as our speakers cover a wide range of topics to expand our knowledge base revolving around the current understanding of temporomandibular disorders as well as their management. Now, for the first speaker of our scientific session is Dr. Aishwarya Nair, Associate Professor, D.Y. Patil Dental College, Mumbai, and her topic of presentation is temporomandibular joint internal derangement, pathophysiology. Over to Dr. Aishwarya ma'am for her presentation.
Chandru, you have to share the screen. Chandru.
Yes, sir.
Good evening, one and all. At the outset, I would like to thank the entire organizing team of this web conference. It is an absolute honor to be a part of this. So I'll be speaking about internal derangement. The pathophysiology is what I'll start off with. Yeah, I'll not go into details of the normal TMJ anatomy, as all of us are aware of it, but I cannot start off a talk on pathophysiology without briefing on this. So as all of us know that there are 2 articulating surfaces of the temporomandibular joint, which is separated by an articulating disc in between, which is divided into 3 parts, and the condyle in a normal joint articulates in the intermediate zone. The posterior part has retrodiscal tissue, which is highly innervated and which is also one of the main reasons which cause pain in the temporomandibular joint disorders. And all of this is enclosed in a capsule, which is filled with synovial fluid, which acts as a lubricant. Now let us talk about the basic TMJ movements. When a person opens the mouth, the movement happens in 2 phases, that is the early phase and the late phase. The disc primarily divides the joint into 2 parts, the superior joint space and the inferior joint. The first movement, that is rotation, occurs in the early phase. It occurs between the inferior joint compartment, that is between the inferior portion of the disc and the condyle, where the condyle rotates around an axis, and there is no translatory movement of the condyle in that phase. But in complete mouth opening, in the late phase, there is translation of the condyle disc complex along the posterior slope of the eminence. Now, this is facilitated by the lateral pterygoid muscle, and it is restricted by the contraction of the superior retrodiscal lamina. Now, when we talk of TMJ movements, we should also know what are the muscles involved in those movements. During opening mouth, the muscles that are primarily involved are the lateral pterygoid muscles, both the portions of the lateral pterygoid and the suprahyoid muscles. And during closing mouth, the muscles involved are the temporalis, the masseter, and the medial pterygoid primarily. Now, let us talk of how the temporomandibular joint is different than the other joints in the body. It is a unique joint as the articular surface is covered by fibrocartilage instead of hyaline cartilage. It has bilateral diarthrosis, which means the left and the right joint function together always. The condylar cartilage is also a growth center. The only joint in the body to have rigid closure endpoint, that is, the teeth come in occlusal contact, and that is the endpoint. And the disc functions as a shock absorber and a separation between the articular surfaces. Now, before we go into disc derangements, let us talk of what is a normal disc position in a normal joint. Most of the times in a normal joint, the normal disc position is when you draw an axis through the head of the condyle, a vertical axis. The posterior band of the disc is at the 12 o'clock position, like it is seen in the second picture down. Now, the first picture is primarily to say that the disc is an avascular structure, whereas the retrodiscal area is highly vascular, and like I said, is one of the main causes of pain in temporomandibular joint disorders. Now, coming to temporomandibular joint disorders, talking of etiology. The main problem in diagnosis of temporomandibular joint disorders is because the etiology is multifactorial. It is very difficult to pinpoint to one factor which has caused that particular problem, as it is most of the times a combination of factors. Now, when we talk of etiology, there are various factors, primarily macro trauma and micro trauma. Now, macro trauma means any kind of blow or injury to the jaw, which can be a road traffic accident or interpersonal violence, or any kind of fall or blow to the jaw. Whereas micro trauma is constant injury to the jaw, which can be in terms of excessive mouth opening for some procedure, or constant biting onto something, or parafunctional habits, or any other constant injury to the jaw is micro trauma, unlike a blow or a whiplash injury, which is macro trauma. There are various other factors like psychological factors which change the perception and the response to pain, hormonal factors which do the same, parafunctional habits, like I said, bruxism can be one of the etiological factors, the loss of joint laxity or hypermobility is another factor, or any other hereditary or genetic factors. Now, does that mean that an asymptomatic individual who has a normal functioning masticatory system and has any of these etiological factors in life, that is trauma, stress, occlusal factors, parafunction, all of them go ahead and develop TMD? No. It is because the temporomandibular joint is highly adaptive. It is the most forgiving joint of the body, and it adapts to any kind of new change in the temporomandibular joint until the adaptive capacity has the trauma or the force that is applied is more than the adaptive capacity of the joint. So what happens when the force is greater than the adaptive capacity is, this is explained very well in this article, which is published in 2010, that once the adaptive capacity is exceeded, there is dysfunctional remodeling of the cartilage. So there is changes in the cartilage, which leads to hypoxia, which further leads to release of inflammatory mediators. There is free radical release, and there is degeneration of hyaluronic acid in the joint, because of which there are inflammatory cytokine production, which leads to cartilage breakdown. That is the process how a person whose adaptive capacity has been exceeded goes ahead and develops a temporomandibular joint disorder. Now, when we see a patient, the patient may present with a muscle disorder, an intracapsular disorder, a primary intracapsular and a secondary muscle disorder, or a primary muscle disorder with a secondary intracapsular disorder. Now, if we see patients of the first and second category, we are lucky because it is very easy to diagnose and also manage. But the problem and the challenge arises when we see patients with the third and the fourth category, where it's a combination of both, where you have to first decide which one to treat first and which is the actual cause of the pain. So now when we talk of pathophysiology of TMD, let us divide it into two parts, the muscle disorders and the intra-articular disorders. Now there are three factors: predisposing factors, initiating factors, and perpetuating factors. Now what do they mean? Predisposing factors means factors which may increase the risk of a person to get a temporomandibular disorder. Initiating factors are factors which lead to the onset of the temporomandibular disorder, and perpetuating factors are factors which can lead to progression of the temporomandibular disorder. Now, a patient may have a combination of these factors or have one of these factors. Now, in a person who has one of these factors or a combination of these factors, and also the etiological factors which we spoke of, when a person has a combination of these two, and it's primarily a muscle disorder, let us talk of how it develops. It develops by when these factors are combined, there is muscle hyperactivity, which leads to abnormality in local muscles that is called trigger points. That are points which are extremely painful, which leads to altered muscle mechanics and maxillomandibular disharmony. Now, all of this, once there is maxillomandibular disharmony and there is abnormal muscle activity, all of this can lead to pain, altered jaw movement, and in further can also lead to intra-articular disc derangement disorders. Now, some patients who have muscle disorders do not progress to intra-articular disc derangement disorders. It is not necessary every person who has a muscle disorder does progress, but it is also possible that a muscle disorder can later on go ahead and cause intra-articular disc derangement disorders. Now, the same thing on the other side, when we speak of intra-articular disorders, when there are any of these factors which cause TMD, along with the etiological factors, what happens is there is joint inflammation and there is biomechanical alterations in the joint, which leads to joint articular surface alteration. There is the articular surface changes in the joint, which leads to poor coordination of the intra-articular movements, which leads to adherences and various other factors inside the joint, which all of these factors together can again lead to pain, limited jaw movement, and joint noise. That is how there is a intra-articular disorder progresses. Now, any of these, the muscle disorder or the intra-articular disorder, can also be combined by it being centrally mediated in certain patients. Now, if we talk of etiopathology of internal derangement, the three main factors which cause it, if we summarize it clinically, is that it is loss of self-seating capacity of the disc or some changes in the disc morphology. The discal attachments, that is the posterior and the collateral attachments, lose their laxity or they become elongated, because of which they are not able to hold the disc in the right position. And there is incoordination of the lateral pterygoid muscles with the discal attachment. Now, when we classify internal derangement, derangements of the condyle disc complex, it is the most accepted classification is the Wills classification of internal derangement. I'm sure all of us are aware, so I'll not go into absolute details of it. But basically, it's divided into disc dislocation with reduction and disc dislocation without reduction. Now, with reduction can be partial or complete, and without reduction can be acute or chronic. This is another classification given by the American Society of Temporomandibular Joint Surgeons, where they have explained it into 5 stages, where stage 1 being early and stage 5 being late. It is a very good classification where they have explained that stage 1 has painless clicking and no restricted movement, whereas stage 5 has joint crepitation, severe pain, and severe restricted function. This is another classification by Dr. George Dimitroli in 2018. This is basically a surgical classification or a clinical classification where he has classified it into 5 categories, where category 1 is a normal temporomandibular joint and category 5 is a badly affected temporomandibular joint where there are so much catastrophic changes that most of the things are not salvageable. if you look at this surgical classification, you can say that category 1 would improve with conservative management. 2, 3, and 4 may require some amount of semi-surgical or surgical management if conservative management fails. And category 5 primarily requires semi-surgical or actually surgical management. Now, if we look at pathophysiology of the disc derangements, we can just summarize it into this, that if the inferior retrodiscal lamina and the distal collateral ligament become elongated, the disc is positioned anteriorly by the pull of the superior lateral pterygoid muscles. Now, if you can see this, here is the muscle and these are the retrodiscal laminas that I'm speaking of. So if this does not pull the disc back in right position and the pull is excessive here, the disc will be in an anterior position, which may lead to thinning of the posterior band of the disc. Normally, the condyle articulates in the intermediate zone, but if it keeps articulating in the posterior band, it may lead to thinning of the posterior band of the disc, which leads to displacement of the disc in a more anterior position, and that may lead to functional disc displacement. Now, that leads to a click. There may be an opening click or an opening and closing click. I will discuss that in detail in the further slides, which may progress to a closed lock where the patient says that I am unable to open my mouth completely, which further may lead to disc deformation or perforation, and that may lead to degenerative changes. So that is how it progresses from a disc displacement to degenerative changes. Now, when we talk of disc displacement, the most common disc displacement is the anterior or the anteromedial disc displacement, and the other disc displacements are it can displace laterally, medially, or posteriorly. Again, uncommon, the posterior being the most uncommon. Now, let's talk of disc dislocation with reduction. When we talk of disc dislocation with reduction, let us first talk of this picture. In this is a closed mouth position where you can see that the disc is a little anteriorly positioned. Now, I am going to explain the clicks that are heard in patients with disc dislocation with reduction. In this first picture, the disc is anteriorly located in the closed mouth position. As the patient opens the mouth, the disc again comes back to the normal position where the condyle articulates on the intermediate zone. It snaps back. That is the first click that is heard on opening. Then the entire opening, the disc remains in that position. And when the patient comes to closing, it again snaps back to the anterior position. That is the closing click or the reciprocal click. Now, when such a patient comes to you, the patient will typically come with a history of long-standing clicking. The patient will come with joint noises. If it has been a long-standing clicking, the patient may also say that I have occasionally had a catching, but it has always self-reduced. That is very occasional. When it comes to frequent catching, that means it is a disc dislocation without reduction, and pain, of course. Clinically, the patient will have pain. If you tell the patient to hold the mandible in a protruded position and open the mouth, the clicking will be eliminated. There will be deviation of the mandibular midline to the affected side. That is when the patient opens, the mandible will deviate to the affected side but come back to the midline on complete opening. And there may be a single or a double click like I explained. Now, this is a video where you can clearly see that in the closed mouth position, the disc is in the anterior portion and it is recaptured when the mouth is opened, and again in closed, it comes back anteriorly. That is the two clicks that are heard. Okay. Now, this is another MRI where you can see that the disc is anteriorly positioned here, and this is the closed mouth. And in the open mouth, it is recaptured and it is back in the right position. Now, I will not talk in detail of the MRI as Dr. Nehal is going to do that. Now, when we come to disc dislocation without reduction, let me discuss this picture first. This is the closed mouth position where you can see that the disc is anteriorly positioned, and when the patient is opening the mouth, throughout the opening, the disc is still anterior and it does not get recaptured or it does not come back to the right position. In fact, it stays as an obstruction to prevent the complete translation of the condyle, because of which there is limited opening. So primarily when a patient walks in with the disc displacement without reduction, the history would be sometimes the patient is able to tell you that previously I had clicking, but suddenly my jaw snapped and I heard a pop sound, and after that I have found it difficult to open my mouth completely. Lot of patients give this kind of history of one episode that they remember, but otherwise the patient will complain of locked jaw and pain and clicking, which was there present previously, but now the joint does not click anymore. Clinically, there will be restricted opening, that is 20 to 30 mm. That means only the rotational phase of the condyle is happening, and the condyle is not able to completely translate forward like a normal joint. There will be mandibular deflection to the involved side. There will be deviation in a disc dislocation with reduction, where the mandible will deviate but will come back to the midline on complete opening, whereas in a disc displacement without reduction, there will be deflection of the mandible to that side, as that condyle will not translate, the affected condyle will not translate completely. There's a hard end field, which means the patient has restricted opening, but if you try to open the mouth further, you will not be able to, and it will be a hard end field, and there'll be pain on loading the joint. Again, this is a video where you can see that the disc in a closed mouth position was also anterior, and in an open mouth position, it is still anterior, and the condyle is not translating completely. It remains in the same position in the closed and the open mouth position. Yeah, this is again an MRI which shows that the disc is anteriorly displaced here in the closed mouth position, and it still remains anteriorly displaced in the open mouth position. It does not come back to the normal position, and it obstructs the complete translation of the condyle in the open mouth position. So if I am to summarize this, basically disc dislocation with reduction, if the patient has clinical or functional problems and the patient has a disc dislocation with reduction and it is not diagnosed or treated at the right time, then it may lead to a disc dislocation without reduction, like it is seen in the first picture, where you can see that the disc obstructs the complete movement of the condyle. And if a patient has a disc dislocation without reduction and functional problems, and that is not addressed, then it may lead to abnormal disc morphology or perforation or degeneration of the disc, which may further lead to degenerative changes in the joint, like it is seen in the last picture here. Thank you.
Thank you, Dr. Aishwarya, for such an informative talk. I'm sure that all the participants have a better understanding of the complicated pathophysiology of internal derangement. Now I invite Dr. Nehal Patel, Director, ABMSS Cleft Project in Surat, Gujarat. He will be talking to us on tricks and pearls of TMJ imaging. Over to you, sir.
Good evening, everyone, and welcome to this TMJ conference. And thanks, Tamil Nadu State and Striker, for organizing such a wonderful web conference, in fact. So I'll be speaking more on a diagnosis and the imaging part of the TMJ, internal derangement particularly. So broadly speaking, the TMD we can divide into a major spectrum. One is extra-articular and one is intra-articular. As a surgeon, we will be concentrating more on this portion because most of extra-articular patients, which are the muscular origin, they don't require any surgical or minimally invasive procedure. But in fact, it is our, we should understand the diagnosis and examination so that we can segregate this patient and we can give them justice by giving a more surgical option for intra-articular patient. So I'll be starting with the examination and identification of the patient. So in broad way, the extra-articular is when joint itself is not involved. All the other things like muscle, nerve, ligaments. So when joint is not involved, it is called the extra-articular, or when we call it as MPDS. all these extra-articular problems or the TMD you can just treat with the non-invasive management like conservative treatment, maybe physiotherapy, splint therapy. But when joint is involved, that is those 20% of the cases which we call internal dearrangement. This pathology is specifically to joint, and there are demonstrable indications when this patient actually required minimally invasive or sometimes invasive procedure. So how do we actually separate and diagnose which patient they need a surgical option or conservative treatment? So it is very prudent to do a proper thorough clinical examination of this patient to come with the diagnosis which can give us an idea whether this patient required conservative treatment or they may require a surgical treatment. So TMJ hypomobility can be divided, as I said, in extra-articular and intra-articular. We will be focusing more on this complex, that is internal dearrangement and the degenerative joint disease. We will not be talking more on the extra-articular. I think that will be get covered in the conservative treatment. So how do you diagnose? So as I said, the most important thing is to patient identification is a clinical examination. So how do you proceed with that? So actually what I do is I have prepared a questionnaire. By most of the time the patient fill that form. So it reduces your time to take a history. And second thing, when they fill up the form, they give a proper history. And at the end of the form, there is a diagnosis portion where you can actually write. So this is actually my form where it's a 4-page form, which a detailed history you can. And at the end, there is a portion for the diagnosis and treatment. So when you diagnose the patient with the internal dearrangement, I am sure that this patient is mine. Or when I know that there is an extra-articular problem or there is a muscular problem, I divert those patients to the concerned person. So how do you start? So you start with the palpation of both the joint, muscle of mastication, accessory muscle of pain. So temporalis muscle, check for any tenderness or trigger point. Most of the MPDS patient, they tend to have a trigger point near the temporal muscle, the anterior part of the temporal muscle. Then bilateral masseter and pharyngomacentric sling. Patient with muscular problem will show a trigger point near the pterygomacentric sling also. Then you move forward and palpate medial pterygoid and incision of the temporalis muscle. Then occipital bone and trapezius. Since it is a musculoskeletal system, one side of the muscle, when they start involving either with the spasm or any other myalgia or myositis, all the muscle which involve in the system start involving itself and cause a pain. Then bilateral joint for the any tenderness or crepitus or maybe popping sound inside the ear where there is an attachment of the retrodiscal ligament. Then you start noting down all these findings, and we have to record the range of motion. Mouth opening, pain-free mouth opening, with pain and with the passive stretch. Sound and the position. Now, what is the importance of sound? Like say there is a clicks, that means the joint is partially involved or maybe there is anterior disc displacement with reduction. And sometimes patient give a history that my joint was clicking few months back, but now there is no clicks, but I have a reduced mouth opening and I have a pain in my joint. That means the joint which was clicking is anterior disc displacement, which has progressed to anterior disc displacement without reduction, and now patient is closing on the retrodiscal ligament and causing a pain. Crepitus means there is a bone-to-bone contact. I mean, when you see here a crepitus, that means there is a direct bone, glenoid fossa and a condyle are in direct contact, and there is a, either tear or there is a thinning of the retrodiscal ligament. And load test. Now this is also important. Now what is a load test is, it is called a Mahan test. Usually you put a wooden stick on the premolar and ask the patient to bite. If there is a joint on the contralateral side that is opposite joint involved, it will cause a pain because of the loading of the joint on that side. That means if you put the wooden stick on the left premolar and if patient gives a pain on the right side of the joint, there is a possibility that right side of the joint is involved with some type of pathology or inflammation. Same way, if the pain is on the same side, say patient is biting on a wooden stick and if they give a pain on the same side, that means there is a pterygomesenteric sling which may be paining and causing a pain. Same way, the lateral extrusion can give you an indication of joint involvement. Movement of the mandible on the right side, when it causes a pain on the left side, that means there is some sort of inflammatory change which is happening on the left side of the joint, on the contralateral side. After all this thing, when you want to confirm, now say if you have a patient who is not responding to any conservative treatment or medication, and you want to go on further and proceed for any minimally invasive procedure, to confirm that joint is involved, you can give an intra-joint injection of 1 ml of plain lignocaine. If the joint is really involved and there is inflammatory changes, after 1 ml of lignocaine, the pain will actually subside or it completely goes away. That means your any minimal invasive procedure, say arthosynthesis or arthroscopy, will give a beneficial effect to that joint. If it doesn't go, say patient says only my 40% of pain is reduced after that injection, that means there is some other component or extra-articular component which is involved. You have to look for the muscular origin of the pain. So now coming forward, so what type of imaging actually do we do for the internal derangement? So it involves, most of the time what we do is when we see a patient with the TMJ problem, we tend to give them orthopentagram or maybe CT scan, ultimately MRI. So the problem with normal panoramic, OPG is it gives a two-dimensional view, and most of the time in internal derangement, the soft tissue, that is a disc, retrodiscal ligament, lateral pterygoid muscle capsule is more involved than the bone. So in early stages of internal derangement, it is difficult to identify on the OPG unless and until there is a real bony changes which involves the joint. So there are limitations of orthopentagram, namely you cannot see soft tissue abnormality. If there is acute stage and say there is a effusion in the joint, it is difficult to identify and see on the X-ray. And very small or localized defect, or say very early stage of Wilks 4, where bone is also involved and there is a mild erosion, it is difficult. And it gives only one aspect of the joint. It does not give a three-dimensional view of the joint. Although sometimes it tends to give a false impression of the adaptive changes. Now this OPG, when you see, is an old age patient with the adaptive changes in the joint without having any problem. But when you look at the OPG, you will see that there is a flattening of the condyle, which can give an impression of the pathology, which is not. This type of, this is adaptive changes which they do not require any type of treatment. So this is what we have to understand. When TMJ is involved, say, even if it is anterior displacement without reduction, but when it is not giving any trouble to the patient, you do not have to treat those patients. The patient is adapted to that particular condition. So actually, it's saying that you cannot or you should not treat the MRI, CT scan, or orthopentagram or internal derangement. Rather, you treat the patient by identifying their own sign and symptoms. Very gross osteophyte formation you can actually identify on the OPG, but ultimately you need to go forward and get the MRI. Now, open and closed mouth of TMJ. Now, what it does give you is an idea that whether there is a rotational and sliding component is proper or not. Say there is anterior displacement without reduction and without condylar or bony involvement. And if you take this open and closed mouth, in open mouth position, you will see the rotational movement, not in the gliding movement on the articular amines. So that will give you indication that there is some problem or disc is stuck, and correlating with the clinical assessment, you can come to know that this is anterior disc displacement or some sort of internal derangement. Same way, CT scan can give you a three-dimensional view only when there is a joint is involved or there is a bony component which is involved. It is very difficult to identify a soft tissue component of on the CT scan. So now when you see the normal anatomy of the CT scan, you can actually identify the changes which happens in the bone, or maximum you can identify is the joint space. Say there is a thinning of the retrodiscal ligament when the disc is stuck anteriorly. You can see on the CT scan the joint space will be reduced here. So it's a normal joint where this space is occupied by articular disc on the CT scan. But when the disc is stuck anteriorly and there is anterior disc displacement, this space is, or the glenoid fossa is occupied by retrodiscal ligament. So you will see a reduced joint space on the CT scan. So what diagnostic information you can get on a CT? So you can see the shape of all the bony compartment, then information on all aspects of the joint, the condition of the articular surface, not the disc. If there is a bony involvement or the articular surface, there is osteophyte, so there is a roughening of the articular surface, or maybe some other things which has involved bone, you can see there. Then size of the joint space, as I showed you, and very unlikely, but you can check the integrity of the disc and soft tissue attachments. So here another scan where you can see there is a flattening of the complete condyle. There's one more here. You can see the osteophyte, small osteophyte formation on the head of the condyle. Then here in the closed mouth position, you can see the condyle is resting on the eminence. That means the posterior part of the glenoid fossa is occupied by some soft type of soft tissue. This is a posterior disc displacement actually case. So disc was moved posteriorly and the entire joint space was occupied by a disc. So it has pushed the condyle anteriorly. So in the closed mouth position also, the condyle was resting on the eminence. Now MRI. So MRI is considered as a gold standard evaluation of the disc position, because as we all know, MRI can give you detailed view of all the soft tissue component, including the disc, muscle, retrodiscal ligament. It can also show the disc deformity, pathologies of soft and hard tissue of TMJ and musculatory muscle. So accuracy of the evaluating disc displacement is 73 or 95%, and osseous change is around 60. This is all from the literature, 60 to 95%. So in MRI, depending on the uptake of the H ion, it gives a different appearance on the MRI. So when the H ion concentration is high in a tissue, MR signal uptake will be high, so it will appear as a white. So most commonly we'll see in the fat. When it is intermediate, the MR signal intensity will be intermediate, it will appear as a gray. So bone marrow and muscle, bone marrow and a muscle will appear gray on the MRI. And when it is a low, particularly in the cortical bone, air and water, it will appear as a black. And different combination of TR and TE, which will allow a discrimination between the different tissues. So what we have to understand is, in T1, you cannot see actually or differentiate between the effusion or effusion. So in T2 image, if there is a effusion, say joint cavity is filled with the fluid, that fluid you can see as a white in T2 image. So how do you actually recognize T1 or T2 images? You have to look for the CSF. In MRI plate where the CSF is white is a T2 image, and in a T2 image, when you see something as a white color in joint space, that means there is a fluid collection or the effusion. I'll just show you one of the image. This is a sagittal section. You can clearly see there's a grayish color marrow space comes as a gray. Then lateral head of the lateral pterygoid muscle, you can differentiate between upper and lower head of the lateral pterygoid muscle, which appears as a gray. Since the disc is basically avascular, you will see as a black, and a retrodiscal ligament and posterior disc attachment. This is a coronal section of the TMJ, where you can see a mandibular condyle, and on the top of the mandibular condyle there is a disc which sits from the medial to lateral pole. So in MRI you can actually see all the aspect of the jointing, and you can diagnose disc displacement, integrity of the disc and its soft tissue attachment, effusion, as I said, in particularly in T2 weighted image, and integrity of the articular surface. I'll just show you how do you check. So when you see any MRI, this is a central section, you can just see here. Since there's a cortical bone or periosteum, you can see a black line surrounding the condyle. In between the black line, there is a marrow space which appears gray, disc appears black again. So this is a case of anterior disc displacement with reduction. So when patient is opening the mouth, disc actually comes on the top of the condyle. That means it is reducing. And when the patient is closing, it remains anterior to the condyle instead of coming top of the condyle. So it's anterior disc displacement with reduction. In this case, you can see during both open and closed mouth, the disc remains anterior to the condyle. That means there is anterior disc displacement without reduction. You can see this continuity of the black line surrounding the marrow space. That means there is no bony involvement. Same way, there is no breach in the continuity of the black lining around the glenoid fossa. That means there is no erosion in the glenoid fossa. Here again, the lateral displacement. You can see the disc is bulged on the lateral side here. This is a medial displacement, same way as a lateral displacement. And this is a posterior displacement. So this when patient opens their mouth, and as I showed you in the other case, when disc has occupied the glenoid fossa, sometimes when patient close the mouth, the condyle tend to remain on the articular eminence here, and the entire fossa is occupied by disc. That you can diagnose on the CT scan. Now, anteriorly displaced disc completely deformed. You cannot see the biconcave shape of the disc. Then disc is actually thinned out, degenerated. If you see here, there is an irregularity on the glenoid fossa. That means there is a erosion. The condylar head also, you can see here, it tends to break the continuity and the shape is changed. So this is basically a Wilks 4 or 5 category joint where there is a completely shattered joint. And this is this displacement with joint effusion. As I said, in T2 weighted image, you will see a white fluid collection in the joint, which is an indication of there is a effusion in the joint. So, to summarize the imaging in panoramic or the conventional radiography, you can see hard tissue, but in a two-dimensional, it is difficult to see a soft tissue. Pathology, it's the same way. You can see on a two-dimensional view, but not all the pathology. CT scan can give you good indication of any bony changes, but not the soft tissue. In soft tissue, normal or pathology, or even adaptation. The MRI is the gold standard to actually diagnose any internal derangement. Now the question is whether you get the MRI for all the patients or not. The answer is no, because most of the patients, they actually get cured or managed just with the conservative aspect. And when you decide to go or do some minimally invasive procedure, or say arthroscopy or arthrosynthesis, then you have to get the MRI. So this is a summary if you see something on a panoramic X-ray, if you find there's a soft tissue changes which is difficult to identify, but when you feel that condyle and everything is normal, and when you feel the patient has a sign and symptoms of anterior disc displacement, you can directly go for the MRI. If you see some bony changes, or there is osteophytes or any other body pathology, you can get the CBCT or CT scan. So, thank you very much, and hope you will enjoy the further talk by other speakers. Thank you.
Thank you, sir, for providing us with wonderful tips as well as practical application points. For the information of the participants, the link for the feedback forms will be posted at the end of the web conference. So kindly fill these forms in order to get your e-certificates.
To be a part of
The next speaker of the day is Professor Dr. Chetan Hegde, Professor and HOD, Department of the Prosthodontics, A.B. Shetty Memorial Institute of Dental Sciences. His topic will be on the non-invasive management of temporomandibular joint disorders. Over to Dr. Chetan for the presentation.
Good evening, everyone. It's my pleasure to be a part of the conference in association with the Oral and Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch. I will be speaking on non-invasive management of temporomandibular disorders. Very often we have patients who are complaining of pain in the temporomandibular joint. Quite a lot of them do not really come to us for treatment, but over a period of time, their pain will resolve. This is possible mainly because the tissues of the temporomandibular joint are capable of functional adaptive change. But there is quite a large volume of patients who would definitely require treatment. So these are the common intercapsular disorders what we come across, and today I will be concentrating only on disc displacement with reduction. So disc displacement with reduction will have a combination of treatment that we need to be providing. The first one is intraocclusal appliance using occlusal splint along with physical therapy. Now, if you look into this, this is a disc which is displaced, with reduction. As you can see, the displace is anteriorly displaced. The head of the condyle is articulating against the posterior part of the articular disc, and it exerts some amount of pressure or load onto the retrodiscal tissues, resulting in pain. Now, what we are looking at in conservative treatment plan is we would like to transiently or temporarily recapture the disc back on top of the head of the condyle, right? And this is done by use of occlusal splint. Occlusal splint transiently recaptures normal condyle disc relationship so that it doesn't exert load or pressure onto the retrodiscal tissue. In this position, we would like to apply some physical therapy in the form of moist heat or shower and so forth, helping retrodiscal tissue to recover fast and also to get fibrosed. Once the retrodiscal tissue gets fibrosed, then it can withstand load without any pain. So the goal of our treatment is decrease joint pain. We are only looking at decreasing of joint pain. We are not really looking at to recapture the disc permanently. Also to improve, and we are not really looking at disappearance of the click of the joint. We are looking to improve the function. We are trying to prevent the further damage to the joint, and we are trying to overall improve the quality of life of the patient. So basically there are two types of occlusal splint. One is stabilization splint and other one being anterior repositioning splint. Now stabilization splint is indicated in the early click, whereas anterior repositioning splint is indicated during the late click. What is early click? This is a anterior displacement with reduction. You can see the head of the condyle articulating against the posterior border of the disc as well as exerting some load or pressure onto the retrodiscal tissue. As the patient starts opening his mouth, within around 10 to 15 mm of opening, you can feel the joint clicking. When the joint clicks, the head of the condyle assumes normal relationship with the articular disc, right? So now you can feel the click within 15 to 20 millimeter of opening of the mandible. So this is called as an early click. In this situation, we prescribe quite often stabilization splint. Stabilization splint is always made with acrylic. It is made with rigid material. It is around 3 to 5 millimeters in thickness. It will have a uniform contact of the lower teeth with the splint, right? It is very essential to have uniform contact of all the anterior and posterior teeth, because these splint we are going to use in the patient for a period of 1 to 2 months of time, or sometimes even more. So we do not want the teeth to supra-erupt. So in order to prevent that, we would like to have uniform contact of both anterior as well as posterior teeth onto the splint. So it is, stabilization splint is always recommended when there is an early click, and it is worn, generally it is worn on all the nights. We try to avoid wearing it during the daytime. But if there is not adequate relief of pain, then we advise the patient to wear it even during the daytime, 2 to 3 hours in the morning, probably 2 to 3 hours in the afternoon also, or in the evening. What stabilization splint does, it prevents the condyle articulating against well innervated vascularized retrodiscal tissues, thereby recovery of the retrodiscal tissues. You can also use very commonly practiced by Essex retainer, which what an orthodontist who is visiting your clinic does. The advantage of using Essex retainer is since it is more flexible, you can extend it more towards the almost up to the middle 1/3 of the patient's teeth. So it is more retentive, easy for the patient to wear. It is generally, it is not loose, it's firmly sitting because it has got, it is an orthodontic retainer. What we need to do is, you need to mix self-cure acrylic resin. Once it is in the dough stage, roll it into a rope shape, adopt it onto the retainer or Essex retainer, then transfer it into the patient's mouth and guide the patient's mandible into centric relation position, making sure the thickness of the splint is anywhere from 3 to 5 millimeter thick. So and let the patient keep his mandible in the same position, and you may ask the patient to open and close a couple of times before the material is fully setting. It's very important to ask the patient to open and close a couple of times, because if the material sets, then we will really struggle to separate the splint from the patient's mandible. So once the splint is ready with your mandible, with self-cure resin out there, place it back into the patient's mouth, take an articulating foil of around 40 microns, ask the patient to close again. So now you can see the lower posteriors as well as anterior teeth contacting against the splint. All the excess material, both buccally as well as lingually, other than the cuspal tips, which is marked through the articulating foil, has to be trimmed, so that there is no overlapping of the lower posteriors or the anteriors. So the patient is free to move his mandible to right lateral, left lateral, or protrusive position, so that his mandible is not really locked. Stabilization splint is always given first for a period of 1 week on a testing basis. If the patient's pain decreases, then you ask the patient to continue the use of splint for around a month and a half, probably to 2 months, till the pain completely disappears. If the pain doesn't reduce or if the pain increases, then you need to discontinue use of stabilization splint and you need to change the design into an anterior repositioning splint. Now, anterior repositioning splint, when do we give anterior repositioning splint? We give this during when we have late click. Let's just check what is late click. You can see the disc is displaced, anteriorly displaced. Patient opens his mouth, right? Only towards the end of the opening, the disc which is anteriorly displaced gets recaptured on top of the head of the condyle and assumes a normal relationship. Now you can see the patient's mouth is almost completely open, or probably 35 to 40 millimeter wide. So if you give a splint at this particular height, then the patient will not be able to wear a splint which is 35 millimeter thick, because the elevator muscles are completely stretched and the depressor muscles are completely heavily contracting. So it's impossible for the patient to wear. So what we do is, in these cases where the click is late, we ask the patient to protrude his mandible. As the patient protrudes his mandible, comes down the slope of the glenoid fossa, you can feel the click, right? So as the patient protrudes, once you are able to feel the click, that means the articular disc assumes normal relationship, just like how it is here. So the patient is merely protruding his mandible, the disc is recaptured with minimal opening of the mouth. The mouth opening is around 4 to 5 mm to maximum, right? So anterior repositioning splint, it provides occlusal relationship that maintains mandible in least forward position to re-establish normal condyle disc relationship. Anterior repositioning splint is advocated only when stabilization splint is unable to provide adequate pain relief. It prevents the condyle from articulating with well-innervated vascularized retrodiscal tissues. It is advocated to be used for a period of 8 to 10 weeks. Ideally, it should be worn in the night, but if the relief of pain is not adequate, you can advise the patient to wear it also during the daytime, 2 to 3 hours in the morning, 2 to 3 hours in the evening. I always advise the patient to wear it in the daytime also, so that condyle is held over the head of the condyle and the retrodiscal tissues are relieved of load for quite some time. So how do you fabricate? First, you make a stabilization splint as explained earlier. Put the stabilization splint into the patient's mouth. Place your index finger on top of the condyle, right? Now, ask the patient to protrude the mandible forwards. As the patient protrudes its mandible forward, you will be able to feel the click. Moment you feel the click, you tell the patient to stop, right? So you can see the patient is almost come to edge position in protrusion, right? Now you ask to place a articulating foil and ask the patient to close again into that protruded position, right? You can appreciate the articulating, incisal edge, articulating against it, against the maxillary splint in an anterior position. Now you take a round bar and make a slot. Make a slot in here into the acrylic, put it back into the patient's mouth and ask the patient to train the patient to close it into this particular slot, which is anterior, very close to edge position, where the click will be completely, where the head of, articular disc is reduced. So let the patient practice closing into this particular position or into this particular notch what you created on the splint. What you do is now you take your acrylic resin, place it onto the occlusal aspect, Guide the patient to close it into this anterior position, allow the acrylic resin to set. Once the material is set, ask the patient to open, trim off all the excess. So the patient knows exactly where he needs to occlude his mandible against the anterior repositioning splint, where the disc would be reduced on top of the head of the condyle. So this is a centric stabilization splint. You can see the mandible. This is an anterior repositioning splint. You can see the mandible protruded and positioning itself onto the splint. So physical therapy modality is a must along with anterior repositioning splint, which is physical therapy modality with the anterior repositioning splint will enhance fibrosis of the retrodiscal tissues. It will, after the pain has reduced, the appliance can be gradually, use of appliance can be gradually reduced. A transient open bite might be seen in the morning. When the patient wears his splint through the night, in the morning, the patient might complain about transient open bite. That will be all right as the patient removes the splint and tries to occlude his within a 30 to 40 minutes, it will be all right. In long-standing chronic pain patients, it is beneficial to do arthrosynthesis before you could give patient anterior repositioning splint. Following reduction in pain upon using anterior repositioning splint, the condyle will function against the adapted fibrous retrodiscal tissue, so the patient's pain will disappear. So along with this splint, it is always a must to provide physical therapy. So these are the various physical therapy modalities, but my favorite is moist heat therapy, because moist heat therapy can be a home care for the patient. So as the patient is wearing the splint inside his mouth, patient can give moist heat therapy, which would help in fibrosis of the retrodiscal tissues as well as the repair of the retrodiscal tissue. What moist heat therapy would do, it will bring about vasodilatation, it improves the blood supply of the retrodiscal tissues, it removes the metabolic waste products, and by stimulation by means of heat, it helps in fibrosis of the retrodiscal tissue. It also reduces pain because the heat is carried through A beta fibers and it masks nociceptive input from the C fibers. So how the patient should do moist heat therapy? Ask the patient to boil water. Once it bubbles, allow it to cool for around 12 to 15 minutes of time. Then take a square shaped towel, dip it inside the water for 3 minutes, fold the towel, ask them to make 4 to 8 folds and get a square form. Now you place the towel on top of the condyle or top of the joint. And he should maintain that hot, moist towel in this position for 15 minutes. And he can repeat this 3 times daily. So after a week's time, when the patient feels better, you advise patients to do resistant exercise, isometric exercises against the palm, against the force against the palm. This will bring about muscle strengthening also, as well as relaxation of the opposing muscles. Patient education is a very important point to be told to the patient. Ask him to have soft food, ask him to chew slower, ask him to make the food into small bits and pieces and eat. No eating from the anterior teeth. Ask him to be careful not to open fully while yawning, and do not allow the joint to click. These are the instructions what you need to be giving it to the patients. Minimum time that is required for non-invasive treatment to be effective is around 45 days, probably up to 2 months or 2.5 months. So both the patient as well as the doctor, both has to be patient. So to conclude, temporomandibular joint is capable of undergoing functional adaptive changes. Goal of the treatment is to reduce the pain and improve functional comfort. It is essential to understand functional aspect of the intracapsular disorder to render appropriate treatment. Conservative treatment is often successful, but it is time dependent. So over a period of time, if conservative treatment is not at all effective, then the patient is possibly only can be treated by surgery. Thank you for your patient listening, as well as for a very good given opportunity to me. Thank you very much.
Thank you, sir. Thank you very much for your clear explanation of the role of non-invasive management in TMDs. And dear participants, if you have any questions, please post it in the Q&A section. The questions will be addressed by the panel during the panel discussion by Dr. Jimson and Dr. Vandana Shenoy. And over to the next presentation now. Can we go on to the next presentation, please? Yes. The next presentation will be on minimally invasive TMJ surgery, arthrocentesis by Dr. Vishal Bansal. He is the professor and head of the department at Subharti Dental College. Over to you, sir.
Thanks for organizing committee giving me this opportunity. Today topic for discussion is arthrocentesis. Arthrocentesis has been defined as a physical or mechanical action of lysis and lavage of the superior joint space of the temporomandibular joint. TMD disorders are the most common cause of odontogenic pain in non-odontogenic cause of pain in maxillofacial region. Arthrocentesis is found to be a reliable treatment modality for patients with internal derangement and inflammatory degenerative disorders. If you will see the indication for arthrocentesis, purpose of arthrocentesis is lysis of the adhesions and lavage of the inflammatory products like cytokinin degraded protein. Arthrocentesis is frequently used for idiopathic TMJ arthralgia with or without functional disability, sudden occurring severe and persistent limited mouth opening originating in the TMJ due to the disc adhesions either next to the fossa or upper aspects of the articular tubercle. Contraindication are as such no contraindication, but when patient with fibrous or bony ankylosis, extracapsular source of pain, patient has not gone under appropriate conservative or nor surgical or pharmacological management. This includes the contraindications of arthrocentesis. Basic objective of arthrocentesis is flush out of the inflammatory synovial fluid and other elements, provide adequate synovial fluid viscosity, lysis of the adhesions by means of hydraulic pressure. So these all will lead to the decrease the friction between the intra-articular surfaces. If you will see the classification of the TMJ arthrocentesis, basically it has been divided into two parts, double puncture technique and single puncture technique. Single puncture technique is chosen by the surgeon because of two needles seems to be difficult placed in a reduced intra-articular spaces, and during the insertion of the second needle, surgeon has always worried to destabilize the first needle. But single puncture needle can be two type. Type 1, that is where inflow and outflow of the fluid through the same lumen, and whereas type 2 is a single puncture technique where inflow and outflow of the fluid through the different lumens into the one device or one needle. If you will compare the results between the single puncture and double puncture technique, a recent publication in JOMS in 2020, meta-analyzed by the Monitorano, found no difference in the mouth opening and operating time in both the techniques. So as a surgeon choice, both the techniques found to be effective in terms of result and outcome of the arthrocentesis. We will see the fluid selection, which fluid is the best. As per literature also, ringer lactate is the most effective and found to be effective method in TMJ arthrocentesis. Because of reason is because of it is close to the human serum, better tolerance to the fibrous tissue of the articular disc, and it optimizes the acidosis into the joint because of lactate will convert into the bicarbonate, which optimize the acidosis into the joint. We'll see the quantity of the fluid, how much fluid is required. In literature, quantity of the fluid from removal of the biochemical substance varies from 300 to 100 ml. In a study by the Jared et al. Concluding in their study that 100 ml is sufficient for the elution of the protein. Similar results were observed in recent literature as well. So 100 ml of the irrigation is found to be effective in arthrosynthesis. So how much pressure should be used? That is a debatable topic, but normally what we use commonly 15 to 20 ml per minute of the irrigant is used in the manual irrigation, which generally creates a pressure of about 6 to 8 kPa. When there is a severe adhesion, Jura et al. Mentioned a study and concluded that and they have used the infusion of accelerator for the blood bank and maintain the 40 kPa pressure for lysis of the adhesion of the joint. Basically, they have used the infusion accelerator for the blood bag and create a pressure of 40 kPa and found to be used for in severe adhesions. You will see the marking under aseptic protocol. Arthrosynthesis is safely performed under local anesthesia by the auriculotemporal nerve block or with the IV sedation. Patient should be seated at a 45-degree angle and the points of the needle should be marked on the skin according to the that is described by the Holmlund and Hessling, and the same described by the McCain, which is drawn from the middle of the tragus to the outer canthus of the eye. First, for better palpation, assistant can downward and forward pull the mandible in downward and forward direction, and first point can be marked at the middle of the tragus from the 10 millimeter and 2 millimeter at the downward, and second point should be marked at the 20 millimeter from the middle of the tragus and 10 millimeter below to the marking of the 20 millimeter. After that, patient should be asked to do the mouth opening and closing. Once we insert the first needle, so there will be patient should ask the open and close the mouth movement, which will confirm the presence of the needle into the superior joint space. Once this patient will do the mouth, there will be a drop of the fluid which is in the hub, you will see in the hub of the needle, which is called hanging drop method due to the positive and negative intracapsular pressures. Second needle is then inserted at the 20 into 10 marking. Then the hub of the first needle is occluded to prevent the pressure will fall. So the patient is again asked to redo the movements, thereby recreating the hanging draw method into the second needle. This indicates that correct placement of both the needle into the superior joint. Then we can proceed for the lavage for the joint. If you will see what is the depth of the needle should be there. So that is one of the good study published by the Honda et al. And reported a safe distance from the puncture site to the thinnest point of the glenoid fossa to prevent the penetration of the superior joint space to the cranial perforation. So they found that about 27 millimeter with a standard deviation of 2.8 millimeter, needle should not be penetrated to a distance greater than 24.2 millimeter, so to prevent any cranial perforation. I will share a small video. So around 100 ml of the fluid should be used ringer lactate to irrigate the lavage and lysis of the joint. After lavage of the joint, jaw movement should be done in vertical and lateral direction, which will remove the adhesions and suction cup effect of the disc. So post-operatively, which improves the mouth opening. Analgesics like naproxen and indomethacin and pyroxicams are found to be effective as a post-operative analgesics. You will see the results of the arthrosynthesis. Since 1991, Netizen first reported the successful outcome of the arthrosynthesis. As of 2020, the success of the arthrosynthesis is still being reported. As per literature, success rate in the terms of mouth opening, range of mandibular motion, pain on rest, and chewing efficiency is reported to be 70 to 84% in the literature. But there is a marginal improvement were reported in terms of deviation or mouth opening and joint noise. But higher success rate was reported by the Netizen et al., which is account for 91 to 95%. The reason for seems to be their use of occlusal splint for 4 weeks post arthrosynthesis, which prevents the microtrauma to the temporomandibular joint and which will prevent the high positive pressure into the joint, and which is responsible for the continuous inflammation of the temp into the joint. This is another study which is study by Masaki et al. They concluded that presence of interleukin 1 beta and interleukin 6 in synovial fluid may be an indicator for possible unsuccessful outcome of the arthrosynthesis. So some of the studies they have unsuccessful, they have aspirated the synovial fluid and sent for investigation, and presence of interleukin 1 beta and IL-6 they found to be found into the unsuccessful cases. If you see the complication, as such no major complication has been reported except local swelling due to the extravasation of the fluid, temporary ipsilateral open bite, facial nerve paralysis and hematoma, which are the because of transient in nature and temporary, which recovered within few days. There is a role of arthrosynthesis with additional drugs. So these roles of infusion of additional drugs post arthrosynthesis is a debatable. Injection of morphine 10 mg in 1 ml or addition of tramadol in irrigating fluid is found to be effective in severe arthralgia cases. This may be because of their action on mu receptors or opioid receptor into the joint. Single injection of corticosteroid like thimerosal acetonide is also found to be effective method in achieving the early mouth opening because of its anti-inflammatory effect. Hyaluronic acid increases the intra-articular viscosity and lubrication, which has been lost due to the inflammation of the synovial membrane. Hyaluronic acid is considered to be a chondroprotective by binding to the CD44 on chondrocytes. CD44 binding is believed to be a decrease in PGU2 and production and increase heat shock protein 70 productions. So this leads to the decrease in IL-1 and IL-6 expression, which significantly improves the pain-free mouth opening compared to the alone arthrosynthesis. In a study by Manfredi et al., they found and they compared the various additional drugs and concluded that arthrosynthesis plus 5 weekly low molecular weight hyaluronic acid injections showed greater improvement in terms of chewing efficiency, reduced pain at chewing, reduced pain at rest, and mouth opening as compared to the single session of arthrosynthesis. Which is again, if you'll see the orthopedic literature also, similar results were observed by the orthopedician post arthrosynthesis 5 injections per weekly of hyaluronic acid shows greater results. PRP helped to stimulate hyaluronic acid synthesis to enhance the cartilage production and joint lubrication. Platelets actively participate in healing process by delivering a broad spectrum of growth factors like insulin-like growth factors, transforming growth factors, which further helps in smooth movements of the joint. And factor transforming factors like they will be helps in chondrogenesis, bone remodeling, proliferation, angiogenesis, anti-inflammatory effect, coagulations, and cell differentiation, which were observed on 4 weeks by the histopathological examination on rabbits, and clinically and favorable outcome were noticed in terms of joint noise elimination and improvement in deviation of mouth opening. On this hypothesis, we also conducted in our department. We found that pain reduction and painless mouth opening were better achieved with arthrocentesis, whereas joint noise elimination and correction of deviation on mouth opening were better in PRP group due to its reparative and regenerative property. Finally, I will conclude that arthrocentesis is an safe and effective treatment method in early and late stage of internal derangement for severe and advanced cases. The role of arthrocentesis plus PRP plus occlusal splint to be investigated clinically and radiographically with a large sample size. Because of mechanical action of arthrocentesis and regeneration property of the PRP may be an effective method in TMD management compared to the arthrocentesis alone. Thank you.
Thank you, sir, for a comprehensive and fascinating presentation on TMJ arthrocentesis. Can we have the next presenter? Our next speaker is Dr. Gary Warburton, Associate Professor, Maryland School of Dentistry, University of Maryland Medical Center, and R. Adams Cowley Shock Trauma Center. He will be presenting on the topic, Minimally Invasive Temporomandibular Joint Surgery, Arthroscopy. Over to Dr. Gary for the presentation.
Thank you for the opportunity to speak on TMJ arthroscopy. We only have 20 minutes, so it'll be a very sort of cursory overview of the topic. And let's start by setting the scene and talking about internal derangement, which is a term actually that's been used for over 100 years in orthopedic literature. And it's used in the need to represent torn, ruptured, or deranged meniscus. We adopted this in the TMJ. And actually, Sir Astley Cooper was the first one to recognize disc condyle malposition or relationship abnormalities in 1887, and he published this in The Lancet along with its treatment by operation. In the 70s and 80s, the malposition of the disc was really considered the primary problem and the mechanical problem that needed to be corrected. So there was a lot of attention to surgical procedures to reposition that malpositioned disc. In 1979, McCarthy and Farah thought that the disc displacement was part of a progressive problem that would ultimately lead to degenerative joint disease. And so they devised a plication procedure that was popular in the 70s and 80s. However, subsequently, they started to recognize, as did others, that this open joint surgery often led to joint fibrosis and progressed to degenerative joint disease. And that, coupled with the fact that TMJ arthroscopy is effective without repositioning the disc, along with the fact that up to 38% of normal volunteers and asymptomatic patients have displaced disc on MRI scan, and also the fact that this plication procedure in 75% of cases was not stable long term. And so we started to realize that the disc is not really, the disposition is not really the primary problem. And there was a conceptual shift over the last 2 decades to our current understanding where the disc is displaced, but that's an endpoint or a manifestation of a problem that's due to biomechanical failure from an underlying cause, which reminds us that it's essential and to identify the underlying cause and treat that if we have any hope of good long-term success. So arthroscopy in India isn't widely available, and we did an Indian survey with Dr. Nehal, Dr. Sonal, and myself, And we surveyed surgeons, not just TMJ surgeons, and we had 596 respondents. 503 were consultant or private practice professor, PG, and 89% felt confident in diagnosing internal derangement. But almost 70% felt that their training in TMJ internal derangement was poor or non-existent. 40% were seeing more than 10 patients a month, which is a significant number of patients with internal derangement. And 83 of them felt that minimally invasive surgery, arthrocentesis, arthroscopy, played a definite role in the management of internal derangement. Yet only 4% were performing arthroscopies. Therefore, we asked, what is your interest in learning arthroscopy? And 81 expressed an interest in arthroscopic training. An additional 15% said maybe. So there's clearly a lot of scope for arthroscopic training and expansion in India, pardon the pun. This slide shows our surgical options in management of TMJ disorders generally, and it's my surgical pyramid. And arthrocentesis, arthroscopy, you'll see is down at the very bottom of the pyramid, progressing up through disc repositioning, discectomy, and joint replacement at the apex of the pyramid. Most patients enter at this level and can be effectively managed by one of these two. You've just had a lecture on arthrocentesis, and the advantages of arthrocentesis are that it's inexpensive. You don't need a lot of equipment to do it. It's evidence-based, it's effective in all work stages, and it has a low complication rate. However, the disadvantages are that because we're not looking inside the joint, we really don't have any diagnostic capability. We're not taking photographs and imaging inside the joint, so there's no medical documentation. We can't biopsy the synovium, so we can't obtain pathology. And the pictures, or lack of pictures, can't be used to educate the patient afterwards. And really, there's no means of mechanical debridement of dense adhesions like we can with arthroscopy. So that brings us to arthroscopy. And this is the surgical setup with the arthroscope, an operative arthroscope. This is a 30-degree scope. Let's define some levels of arthroscopy that were described by Joe McCain. Level 1 is a single puncture with an outflow needle. We can perform some simple maneuvers, lysis, lavage, diagnostic sweep, needle adhesiolysis, and that's a level 1 arthroscopy. The next level is level 2, where we introduce a second portal or cannula, which is an operative port. And now we can do joint debridement with laser or coblation. We can biopsy with grasper. We can mobilize the disc and reposition the disc with the probe, but not fixate it. The fixation of the disc requires a level 3 arthroscopy with multiple punctures, 3 cannulas and a spinal needle, as you'll see later. And through this, we can now, in addition to repositioning and mobilizing the disc, we can actually secure it either using sutures or screws or wire. So let's think about arthroscopic surgery just for a second. When we consider this, it's important to recognize the difference from open joint surgery. When we perform open joint surgery, we're dissecting through tissues under direct visualization, whereas an arthroscopic puncture is a blind puncture using landmarks. And once we're inside the joint, it's as if we're standing inside the room and we have to look at all 4 walls, the floor and the ceiling to recognize any abnormalities. Joe McCain described these 4 walls and the floor and the ceiling in his diagnostic sweep, 7 areas of interest. So I typically will start over at the medial drape, looking for inflammation, adhesions, villonodular synovitis. Then we look down the medial trough towards the pterygoid shadow. Third, look at the retrodiscal tissue and the posterior oblique band, looking for hyperemia, hyperplastic synovium, perforations, adhesions. Then we look at the eminence of the fossa, which is normally covered by white fibrocartilage. And we look for any chondromalacia. We grade it. We look for any creeping synovitis. Then look at the disc, and the disc can be seen with the posterior band, then look forward towards the intermediate zone and the anterior band, and finally end up in the anterior recess. So that's the diagnostic sweep. The doorway into the room is actually right here, which is the peak of the glenoid fossa. If you look over on the right, you'll see that entry or puncture into the joint is facilitated by your assistant translating the condyle forward, thereby opening up this posterior joint space. And in addition, we insufflate that posterior space to blow it up even further, thereby making the puncture more predictable and accurate. This shows a live level 1 arthroscopy that outlines the procedure. I palpate bony landmarks in order to identify that standard fossa portal or puncture site. Holm and Helsig describe the line and measurements to determine that, but I find that isn't always accurate, so I prefer this technique. So you'll see the assistants translated the condyle forward, and now we're insufflating the joint with solution. This can be either lactated ringers or plain local anesthesia, avoiding epinephrine. We know we're in the joint space because of a few things. One, it's very easy to insufflate. And secondly, as you can see here, we aspirate the fluid out. If we're not in the space, you can't aspirate. Next is we insufflate and generate an appropriate amount of distension, which corresponds to about a ½ cc of plunger rebound using a 3 cc syringe and 22 gauge needle. Then we've blown up the joint space and withdraw the needle. Next, we make our puncture with our sharp trocar and cannula, palpating the zygomatic process of the temporal bone and dropping off onto that puncture site, and then using a rotation pop into the joint space. And then on entry, we remove the sharp trocar. And if the joint's inflamed, we often get some bleeding at this point, so it's important to irrigate or backwash the joint using lactated ringers. So here we're backwashing the joint, and we're occluding the entry to the cannula to drive the fluid in and let it go in and then out intermittently until the outflow becomes clear. And then we pop the arthroscope in, and again this is a 30-degree arthroscope. And once we look at the monitor and confirm that we're in the joint space, then we use the 22 gauge needle again as an outflow, and thereby that maintains a patent irrigation system throughout the entire procedure. And there's our outflow. So now we're in a position to perform that diagnostic sweep or look around the room, 4 walls, floor, and ceiling. If after that we feel that there's a need to do some operative maneuvers, then this shows a second puncture, which is established using vectors and markings, measurements on the first cannula transferred forward onto the second puncture site. And once this cannula is in, then we can introduce probe, we can do laser. Here we're seeing a probe being used. The tip of the probe goes over the posterior oblique band, which is that consolidation of elastic fibers, to pull the disc back and reposition it. There we can see the posterior band and the intermediate zone here, and then the anterior band over there on the horizon. If we see polypoid synovitis or there's a lot of adhesions, then we can use the holmium laser to ablate any hyperplastic polypoid areas. And hyperplastic or villonodular synovitis is a sign of a very inflamed hot joint. And so here you see the laser being used to debride a small area of polyp. So let's look at some cases now. And this is the typical armamentarium and instruments that we need for an arthroscopy. And let's start with a 65-year-old female that came to see me with right TMJ pain and limited mouth opening. She gave a history of this starting 7 years ago with clicking, but the clicking actually stopped a few years back. She couldn't recall any inciting event. The pain was localized to the joint, and that is a surgically relevant part of the history. And it was a constant but variable pain. And we can recognize that by seeing the 6 to 9 out of 10, which means that it was never 0. She was never pain-free. It was always within that range. It wasn't worse in the morning, but it was worse with function. Morning stiffness and pain is an indicator for parafunctional habits, and that's a cause of TMD. Limited mouth opening, which was progressively getting worse, and she denied any other joint pain, which is also another cause of TMD. So we have to rule out systemic arthropathy, and she'd failed the non-surgical management. So in taking your history, you have to pick up on all the points, not only the onset and the evolution, but try to identify any cause. Was there any trauma, parafunctional habit or a systemic arthropathy, and then characterize it further and localize the pain if possible. And if it is localized to the joint, then that may well be a surgical candidate. So now moving on to the exam, she had tenderness and to palpation of the masseter. I start with a muscle exam and also temporalis. This was a local myalgia. The local myalgia, remember, is pain localized to the site of palpation. Myofascial pain is pain that stays within the muscle boundaries, and myofascial pain with referral is a trigger point where the pain is recognized or palpated or appreciated outside the muscle boundary. Incisal opening was very limited. She had a pain-free opening of 5 millimeters, maximum of 23, and with assistance, I could get her to 26. So that's important because that gives us a clue that the condyle really isn't translating much at all. It's really just hinging. And then when she opened, she deviated progressively to the right. And when you palpate over the lateral pole of the condyle, she had absolutely no condylar translation. She had crepitations on auscultation, and she had a direct pressure loading sign that was negative. She did not have a direct pressure loading sign. It was negative, I'm sorry. And that was described by Parker Mahan in his PhD thesis. Class 1 molar, class 1 canine. She had wear facets on the teeth, tongue, scalloping, and buccal ridging that was indicative of a parafunctional habit that may be ongoing, or it may have happened at some point in the past. So at this point, what imaging do we need? If we're suspicious for bony pathology, then a CT scan's indicated. If we're suspicious that it's a disc issue, or in this case, I was suspicious that she had a fibrous arthrosis, then an MRI scan is the best option. MRI scans are a little bit unusual if you're not used to reading them. So let's have a look at a normal MRI. Here we see the condyle seated in the glenoid fossa, so this is closed mouth view. You can see the black cortical rim that's intact. It's smooth, it's round, there are no erosions. The eminence is here, the fossa is here, and this bow tie structure is the disc. The normal position of the disc, the posterior band should correspond from a 12 o'clock vertical line up to 12 o'clock position here from the mid-condylar pole. If you draw that vertical line up, that should be where the posterior band of the disc is. On opening over here, you'll see the condyle is now translated forward. Here's a condyle, and the disc has now come up and roofed over the top of the condyle. That's a normal position disc. This is our 65-year-old patient. This is a T1 image on the left of the screen, and you can see the condyle looks abnormal. First of all, it's very irregular. It's flattened. There's no joint space. The joint space appears to be filled with some fibrous tissue. This is another slice that shows the same thing. This is a proton density series. Proton density is very helpful because it shows fibrocartilage structures very well, and therefore the disc appears clearer on a PD study. Here we have the open mouth images, but it's open, but she's really not translating. This confirms that the condyle and the joint space is stuck. Here's a disc remnant, but look at the contour of the eminence. That's either an erosion here, but she's got some thickened bone here, so this could be either a bony prominence here and a thickening, or an erosion. Same here, we can see some fragments of the disc, and that thickening here, and some thinning here. So on the arthroscopy, we'll see what that actually turns out to be. So the assessment for this lady is that she's got right anterior disc displacement with reduction. She's got a stuck and perforated fragmented disc, moderate DJD. She's got a fibrous arthrosis, and therefore we plan to do a level 2 arthroscopy. And here we are on entry into the joint, and this is a very abnormal joint. The joint should be an empty space filled with synovial fluid or irrigation fluid. There we're looking at that bony prominence. It turned out to be a bony prominence in the roof of the glenoid fossa that we saw in the MRI scan. It is covered by fibrocartilage, but you can see it's surrounded. The posterior recess is filled with adhesions. And prior to insufflation, the retrodiscal tissue was stuck to the glenoid fossa, and the insufflation has lysed some of those adhesions, as did a blind sweep with the trocar, blunt trocar. So I use the analogy here when describing this to patients. Instead of the room being space, the carpet is actually stuck to the ceiling. And here you can see all of those adhesions quite clearly. And we can debride those if you wish with coblation or laser and mobilize everything. But actually the benefit is actually separating and reestablishing a space by the lysis and lavage, and then even a mechanical sweep using probe or blunt trocar. So the next case that we'll look at is a 31-year-old who worked for an embassy in the Middle East, and her complaint was she was recurrently subluxing on the right joint with pain. She had a 14-year history of open lock, started after a wisdom tooth extraction, and now she's open locking several times a day, and it's painful. Again, you can see it's a constant pain, but variable, 2 to 8 out of 10. Pain was localized to both the joint and the muscles. So she's got two components to her pain. Failed non-surgical management. Again, she tried all the non-surgical techniques and failed. On exam, she had tenderness of the right masseter and the lateral pole of the temporomandibular joint. Her incisal opening was 22 millimeters. Maximum opening was 45 millimeters, and with assistance 45. She had an early opening click that suggested a mild anterior disc displacement with early recapture. She had an open lock on the right, and she did have a positive direct pressure loading sign indicative of some retrodiscitis. Class 1 molar, class 1 canine, and again she had some wear facets on the teeth, tongue scalloping, and buccal ridging, indicative of some parafunctional habits. Here's her MRI scan. Here's the condyle. It's nice and smooth. The cortical outline, the black area is smooth without any breaches or erosions. Here's the posterior band of the disc, and remember that should be from mid-condylar pole, a vertical line. This should be where that posterior band is, so it's slightly anteriorly displaced. Again, this is a proton density study, so you can see the disc nice and clearly. This is open mouth. She's not fully open here on the MRI scan at the time of the scan. And here's the posterior band of the disc, so now the disc is reduced. Clinically, she was open locking and subluxing, so she just didn't open wide enough on this particular scan. So her assessment was right mild anterior disc displacement with reduction, and she was having frequent open locking or subluxation that was painful. So for this lady, we were planning a level 3 arthroscopy with suture discopexy. And here's her examination under anesthesia when she's got full neuromuscular paralysis and she's open locking even there. You can see it catching and getting stuck, and then my finger pops it back. So she was open locking even under neuromuscular paralysis. Here's our puncture into the posterior recess with the condyle translated forward, quick diagnostic sweep, medial drape, normal, sweep down the medial trough towards the pterygoid shadow. You can see the pterygoid shadow here. Then we're going to piston out and have a look at the retrodiscal tissue, the posterior oblique band, which represents that consolidation of elastic fibers. Here's an adhesion that was stuck up to the roof of the glenoid fossa. There's some hyperemia, moderate to severe. Here's the disc, posterior band, intermediate zone. Anterior band is over here. The articular eminence is above. There was no chondromalacia. Quick look at the disc in function and a sneak peek into the anterior recess to make sure there are no abnormalities. And then we come back into the posterior recess. And now we're ready to do our operative maneuvers. You can see the fibrocartilage covering the eminence and the fossa. This is quite healthy. There's no breakdown or chondromalacia. So the next step is to mobilize the disc and reduce it. Here's our outflow needle, which we'll exchange for another sharp trocar and cannula. So we'll withdraw that needle and we pop in a second portal. And you'll see that coming in around the 2 o'clock position on your screen. And you'll see the trocar come in. Once that's entering into the joint on the direct visualization, again, we can cause some bleeding in this part, which may need some irrigation. Withdraw the sharp trocar, and next we're going to go in with our operative instrumentation. Here's the holmium laser, just to ablate that area of adhesion and hyperplastic synovium. The next thing we're going to do is contract the posterior oblique band and the attachment, and as you see the thermal impact, it contracts the tissues as we activate the laser, thereby hopefully pulling the disc posteriorly, and with healing and fibrosis that will help the anterior translation and limit the range of motion anteriorly, hopefully preventing that subluxation. So there's the laser procedure completed. And now the next thing is with the probe, we go in and reduce that mildly displaced disc. So now sweep down, and you'll see the disc come down and back as the probe goes down. And there's our ideal target right here in the posterior band of the disc. That's the ideal position for the suture to pass through the disc. So again, there's the probe reducing over the posterior band, pull down and back. And here, now we're looking at our ideal position for the needle, the spinal needle, an 18 gauge spinal needle to pass through the disc, and then subsequently the suture will go through the needle. So the 18 gauge spinal needle is now being inserted just below the tragus to contact the posterior condylar neck. The tip walks medially and then upwards towards the disc. And then you'll see the needle penetrate through the posterior band of the disc. The obturator is withdrawn. So now we've got the position of the suture passing through the disc. The third portal is now introduced, which you really don't see much of. It's you'll see it come in at the 1 o'clock position, but this is your retrieval port, through which we're going to insert a grasper to grasp the suture as it comes through the needle and pull it out of the joint. So now I'm putting in this third cannula, and you'll see a glimpse of it coming in at the top here. There it is, up here. And now through this, we're going to put in the grasper, and then the suture will come through the needle, and we grasp the suture here and retrieve it, pulling both ends of the suture ultimately out through the skin, and then it's tied subcutaneously. So there we are grasping the end. The needle is then withdrawn, leaving the suture passing through the disc. The tension is then applied as the suture is tied down subcutaneously, and that maintains and fixes the position of the disc. You can see the suture actually pulling this disc back now, right? So this is fixing that position of the disc. That's a level 3 arthroscopy. So level 3 is actually not usually required. 80 to 90% of cases, surgical cases, can be effectively managed with a level 1 or level 2. But what happens when that fails? Well, it really depends on what the diagnosis was, and that's where arthroscopy is important and has the advantage over arthrocentesis, because we're looking inside the joint and we can make a diagnosis. So if we've got a diagnosis of early joint disease, Wilks 2, 3, or early 4, then we have the option of repositioning the disc, either arthroscopically or by open joint and Mitek anchor. Wilks 4 and 5, really now we're moving on to more advanced open joint debridement and discectomy, plus or minus disc replacement if you choose. If we take biopsies and they show primary arthritis, then we're making a rheumatology referral, and if it's severe degenerative changes, then joint replacement. So this is another way to look at this. You've done your level 1, 2 arthroscopy, lysis lavage, and it fails. The majority, 80 to 90%, will do well and need nothing more than that. However, 10 to 20% will have ongoing symptoms. So the next question we should ask is the disc salvageable? If it is, then we have the option of doing a discopexy, either open or arthroscopic. And if not, then open arthroplasty. When I'm looking at the MRI scan to identify a suitable candidate for a discopexy, particularly arthroscopic discopexy, I'm looking for a few things. One, the disc has to be a normal shape. It's going to have that bow tie appearance. There's no point reducing an abnormally shaped disc. It's not going to serve much use. If it's perforated, also that's another potential contraindication. But also, if the disc is being displaced for a long period of time, the joint space actually collapses. And then we're squeezing a disc into a non-existing space, and therefore we can't expect that to be stable long term. So if the disc is salvageable, we just do a disc repositioning. If not, open arthroplasty and discectomy. And if that fails and they go on to develop progressive degenerative joint disease, then the last step is total joint replacement. So I hope that gives you an overview of arthroscopy, level 1, 2, 3. We can't cover everything in 20 minutes, but hopefully it's given you a taste and some insight into what arthroscopy can do for our patients to improve their quality of life. And I thank you for your attention. Hope to see you all soon in person.
Thank you, Professor Warburton, for that wonderful presentation explaining the TMJ arthroscopy in detail. And it was a pleasure listening to you, sir. And over to the next presentation. Our next presenter is Brigadier Dr. S.K. Roy Chaudhary, who is serving in the armed force for more than 25 years. He will be presenting on open TMJ surgery. All open surgical procedures will be demonstrated for the benefit of the postgraduates. Over to a fully loaded presentation, literally and figuratively. Over to you, sir.
Okay, good afternoon and good evening, everybody. The topic which I've been given today is open surgical procedures of the temporomandibular joint. At the onset, I'd like to thank the Association of Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch for inviting me for their session. And I congratulate them that I believe that they are doing a lot of webinars for the benefit of the students and contemporary practitioners. So without too much of time, let's go ahead. Now, the spectrum for surgery, as far as the TMJ is concerned, is mainly due to internal derangement, hypermobility, hypomobility, ankylosis, growth anomalies, trauma, arthritis, and neoplastic conditions, as we all are aware of it. Like any other center, our approach is the same. First, we try conservative. In case the conservative is refractory, then we start going for minimal invasive surgeries in the form of arthrocentesis and arthroscopy, as can be seen. Arthroscopy, especially in the form of initial diagnostic arthroscopy, followed by therapeutic arthroscopy. Now, once all these things are refractory and they are not being useful for the patient, then we choose surgical procedures in the form of discopexy, high condylectomy with or without disc repositioning, discectomies, vertical ramus osteotomies, capsulorrhaphies, aminoplasties, glenotemporal osteotomies to create a block in between, and open reduction, internal fixation of trauma in case of fractures, and interposition of gap arthroplasty followed by joint replacement in case of TMDs and ankylosis or any other debilitating disorders of the temporomandibular joint in the form of neoplasm, etc. Now, as far as reconstruction is concerned, we take autogenous grafts from the vicinities, from the distant site. We do tissue engineering in the form of distraction and osteogenesis, and of course, the in thing now is the alloplastic joint replacement, temporomandibular joint replacement. Now, what is leading us to believe certain facts that limited approach to specialty care is there, at least in our country. Meticulous follow-up may not be always possible for such cases. Constant pain affects quality of life. There's reduction in work efficiency. Screening stroke treatment during the initial stages at areas lacking expertise. And long-standing conservative therapy, which is refractory in nature or not useful for the patient, leads both the patient and the operator to search for a treatment facility, which will be short-term, with minimal morbidity, early return to function, and definitely it should be evidence-based, as it is for all types. Now, when do we operate? In moderate to severe pain of TMJ, especially localized TMJ pain, pre-auricular pain, which is not getting corrected with all therapies, and referred pain, for example, otalgia. Dysfunction that is disabling and characterized by any of the following, like restricted range of movement, excessive range of movement, noises in the joints while closing or opening, and abnormal masticatory function. When we have evidence via imaging that there is disc derangement or there is damage to the disc, and of course nowadays with the advent of the arthroscopes in TMJ, there is direct evidence of disc derangement and perforations, etc. of the disc. So when should we operate? The absolute indications are ankylosis, tumors, dislocations, recurrent or chronic in nature, and developmental disorders. Relative indications are like internal derangement, which are refractory to all treatments, osteoarthritis, or any type of arthritic conditions, trauma definitely. Now, what makes us do the thing, like a level of pain that is of little or no concern to what is the outcome of the surgery that is expected by the patient. Improvement in function, reduction of pain, a stable occlusion, acceptable clinical appearance with minimal or no damage to the function, especially the motor functions, limited period of disability, and acceptance of the patient for the procedure and the outcomes, which should be very realistic in nature. Now, how many types of category? We have categorized TMJ into surgical classifications as category 1, in which the TMJ is normal, no surgery is required definitely. And in category 2, we have TMJ with minor changes which can be corrected with minimal invasive procedures like arthrocentesis or arthroscopy. Category 3, where there's moderate changes and people who are expert in level 3 of arthroscopic surgery can go ahead with that, or open surgery may be required. Category 4, severe changes, definitely open surgery may be required in this thing. And category 5, where TMJ, there's catastrophic changes. Nothing in the joint is salvageable. In that condition, we can think of resection and replacements of various kinds. Now, coming to the surgical managements of various conditions, a couple of examples I'll give. Like first is for the internal derangement. Now, in this case, disc repositioning with MyTac mini anchors have been tried by Mehra and Wolford with good result. We have emulated it in our centers. Here you can see an MRI with the disc anteriorly displaced with painful opening of the mouth. Now, this orthodontic mini implants have been used by us, and disc has been repositioned and sutured along with it. You can see the lady in the video with mouth opening, which is not painful, and she is comfortable in her functions like mastication and all. Second procedures which are used in these conditions are discectomies and replacement with abdominal fat graft, which is also having good surgical outcome. Now, post-discectomy changes in the condyle are in the form of osteosclerosis, flattening, development of subchondral cysts, and osteophytes. These changes are mainly adaptive rather than pathological, since these changes are not associated with pain. Now, there's a controversy whether to retain the disc or remove the disc. There have been a lot of studies, but Wilkie's in 1991 after analysis of the studies in 2011, he said that the damages and property and now this progressing is another procedure which is done quite widely, at least by me and in my center, but this is not procedure which you cannot be sure that the results will be 100% or not. Some may show that the results are very good, but in some persons the results are exactly mixed. It is essentially a simple procedure related. It is not required for that. And you see in these cases that the process is done properly. You see the video on the left side. The patient's mouth is restricted with the patient anymore. And there is a limitation on the lateral section that is post-discectomy or post-discectomy. Patient opens the mouth much more than the previous thing, and it is infected functional improvement.
Chandru, audio is not clear. Can you stop and restart? Chandru,
Can you stop it for a while and restart?
can you stop the presentation and restart? Chandru, Mayank, can you stop? Mine, stop the presentation and restart. Stop it and restart.
Direct restraint of the
I'm not able
condyle,
to.
creation of a new muscle balance, removal of mechanical obstacle. Nowadays, we use all these things in as.
Hello, Ram Kumar.
Sir, yes, sir. Hello.
The audio is not clear. Can you?
Please restart the session.
I'll do that, sir.
Yeah.
And I congratulate them.
Sir, shall I from the beginning or? Hello.
Continue, please. Yeah.
From the beginning or?
After 5 minutes.
Good result. We have emulated it in our centers. Here you can see an MRI with the disc anteriorly displaced with painful opening of the mouth. Now, this orthodontic mini implants have been used by us and disc has been repositioned and sutured along with it. You can see the lady in the video with mouth opening, which is not painful, and she is comfortable in her functions like mastication and all. Second procedures which are used in these conditions are discectomies and replacement with abdominal fat graft, which is also having good surgical outcome. Now, post-discectomy changes in the condyle are in the form of osteosclerosis, flattening, development of subchondral cysts, and osteophytes. These changes are mainly adaptive rather than pathological, since these changes are not associated with pain. Now, there's a controversy whether to retain the disc or remove the disc. There have been a lot of studies, but Wilkes in 1991 finally summed it up after analysis of many studies, including his own, and said that decision depends on case-to-case basis, disc anatomy, damages and perforation, and center-based protocol definitely, which is definitely there for all centers. Now, discopexy is another procedure which is done quite widely, at least by me and in my center. But this is one procedure which you cannot be sure whether the result will be 100% or not. In some people, the results are very good, beautiful, but in some persons, the results are refractory in nature. It is a simple procedure relatively. Very small openings are required for that. And if you see in this case, a discal procedure has been done properly. If you see the video on the left side, the patient's mouth is restricted, there's deviation in opening, and there's limitation on lateral excursion. Whereas post-discopexy, patient opens the mouth much more than the previous thing, and she has gained weight because her function has improved, I think so. So that could be another disadvantage of discal procedures. As far as high condylectomy is concerned, we have this high condylectomy done when there are severe bony changes in the articular surface, especially condylar hyperplasias, fibrous ankylosis, and a very controversial thing is non-reducing disc displacement, which is very controversial in nature, and nobody knows whether it is there or not. It is quite refractory in nature. Like in this case, the patient which we see, if you see in the orthopantomograph, you see a huge osteophyte kind of thing. In the MRI, the disc is much anteriorly placed and dislocated, very painful opening, restricted opening. We went for high condylar shave and discopexy of the patient, as it can be seen here. And you see the patient opening the mouth. There's a mild deviation of opening. There is, but it improved subsequently on physiotherapy and practice of intraincisal opening. Another procedure which is done is vertical ramus osteotomy, which increases the joint space, decreases the joint loading, decreases the pain-related symptoms. This is one procedure in which the joint is treated without involving the joint directly. That is why in many centers this is preferred. If we have the equipment and the expertise, we can go for intraoral vertical ramus osteotomy. And secondly, no joint fibrosis as in other procedures are there in these conditions. Now the next is hypermobility, which is again a very common phenomena seen. In 1976, Miller and Murphy divided the surgical procedures to correct the recurrent condylar dislocations into basic 5 categories. That was capsule tightening procedure, creation of a mechanical block, direct restraint of the condyle, creation of a new muscle balance, removal of mechanical obstacle. Nowadays, we use all these things in as isolation or in mix and match as per the situation of the case. Here you can see in the video, especially in the lower video, how much of terminal jolting is there in this lady, how much of excessive movement and jerking back is there. MRI is self-explanatory with the disc anteriorly positioned. In this case, we went for a capsulorrhaphy and reinforcement of the area using temporalis fascia with very good result. This is another case in which recurrent dislocation is there. If you see the orthopantomograph, we see how much of movement of the condyle is there beyond the articular eminence. And look at the interincisal opening. More than 5 centimeters, more than 50 millimeters, 5 centimeters. In this case, we went for a graft from the mentum area and went for a glenotemporal osteotomy, which resulted in a reduction in the mouth opening to 37 millimeters. Subsequently, it further reduced a little because of operatic fibrosis. Cases of hypomobility, actually hypomobility is relative. This is when the disc has displaced and it is not reducing. Patient has very good difficulty in opening the mouth because of the hindrance. There is spasm in the muscles of mastication. This results in very painful opening, as can be seen in this MRI. So in this case, we go for disc repositioning after we do an aminoplasty. We flatten the articular eminence, we relocate the disc back, and we do a discopexy on that. You can see immediate intra-op view of the joint, which is smoothly gliding over this space which had the eminence and flattened, and the disc is relocated and tightened over the condyle stump. Now the next condition is ankylosis, which all of us have treated, at least in our country, in loads. Ankylosis is one of the most debilitating condition of the temporomandibular joint, in which the patient has so many problems, mainly aesthetics, function, mastication, obstructive sleep apnea. And it can only happen in third world country like us, where we have patients who are almost adult or fully adult with faces like this and not seek treatment, which makes the treatment so difficult. Because if you see the CT scan here, you see that huge ankylotic mass, which is completely obliterated the infratemporal fossa, the thickening of the subcondylar area. There is no anatomical demarcation. So these can be treated either as interpositional gap arthroplasty using temporalis fascia and using the coronoid after coronoidectomy as a graft. It is very important to go for post-operative physiotherapy in the form of mouth exercises and to ensure that the mouth opening remains constant. Another case with a good amount of ankylosis here, you can see the CT scan as well, both the section 3D as well as the section there, in which we went for gap arthrectomy followed by a replacement of the joint, as can be seen here as a joint replacement. In this case, this is the post-operative mouth opening, this is the post-operative radiograph here, orthopantomogram. Another case, these are very difficult cases because you have huge coronoid, a massive ankylosis, a bird's face, literally no corpus of the mandible. So these are the cases which require multi-therapy, not only addressing the joint, but also addressing the corpus of the jaw. So here we went for initially a distraction osteogenesis of the ramus. The patient had still the ankylosis. If you see the radiograph here, we placed the distractor at a particular angle and we started increasing the angle ramus area. so that we have enough vertical space to place our joint when we use the joint. After consolidation, we removed the distractor, did the gap arthroplasty. That was followed by replacement of the joint, as can be seen here, and simultaneously genioplasty. So this is the post-operative radiograph of the individual interincisal opening, and the patient is doing quite well. Coming to the next case, this is one case where we use a costochondral graft, which is generally not used so much nowadays. The patient is an adult. There were some constraints, administrative constraints and economic constraints. So the patient had to go for a graft, and we counseled her regarding that thing. She agreed to go for a costochondral graft in this case. So here we see a CCG done here. The result was averagely okay. I won't say very good, but averagely okay. The best part was the interincisal opening was maintained to about 35 millimeters without any stretch. Now these cases are again very difficult cases, like the previous one which I said. Hardly any chin, hardly any corpus of the mandible, huge block of ankylosis. The other side is normal. So in this case, again, we went for the distraction of the ramus, as you can see, but we did the distraction for bilateral ramus angled, so that there is increase in the corpus. Subsequently, we went for joint replacement after consolidation. You can see, once the joint was taken up and the function established, then we went for a body distraction, bilateral body distraction, and asymmetrical distraction, in which we opened the left side more and kept on opening and closing the right side, as we call in asymmetrical distraction. This is during the consolidation phase of the body distraction, and this is the post-operative view, and you can see the video. The patient has started masticating and function is good. Subsequent rehabilitation after orthodontia of the missing dentate part will be taking place. This was another challenging case in which there was bilateral TMJ ankylosis, as you can see in the orthopantomogram, and this is a case of ankylosing spondylitis, complete ankylosis of the cervical vertebrae. This individual also had bilateral hip replacement. Now you can see the coronal views in which the ankylotic masses can be seen. The patient positioning was very important because the head could not be turned. So the patient had to be locked on the OT table at lateral positions, both sides. Simultaneously, both the joints were operated. We did a bilateral gap arthroplasty, followed by bilateral TGR in the same sitting, changing the position of the patient. This is the postoperative orthopantomogram and the PA mandible and lateral ceph. And this is, you can see, in between is the center is the intra-op, left is the intra-op, and right is the post-op. 7 days post-op of the patient. Patient went back very happy, functionally stable, and could eat properly. We have had the good fortune of using navigation surgery for temporomandibular joint ankylosis cases. Now you can see this is the patient on the left side, we can see, and after the surgery, there is a difference in the look and interincisal opening. This is a very expensive equipment. It will take a lot of time for our country to get such equipment. But we are very lucky to use it only in one patient as a trial basis before procurement for the system by the government of the country. The system is very clear. Here you go for a CT angiogram, you go for a 3D CT scan, and then with the markers, as it is shown here, there's an antenna on the forehead. These markers are, these data is fed into the machine. The markers mark the area where you have to operate. It isolates and delineates the vascular elements. The infratemporal fossa, all vascularities were easily seen by it. You have to use a sterile receiver or a transducer or an antenna on the scalpel and on the handpiece, which is sensed by this antenna on the forehead, and in turn it is transmitted to the machine. So when we are operating, we see that something like this. On the left, you see I'm operating. On the screen, the thing is coming. And if you see this three-dimensional thing where my cursor is moving, you can see a pen-like structure. That is actually my handpiece. So I'm blindly cutting. And believe me, this case was operated within 50 minutes, de-ankylosed. Unheard of. Because we are safely, as soon as you get near a vascularity, as can be seen here, there is a beeping sound. And you change your position. this is how we are supposed to cut here. This is an amazing technology, but it will take some time for the country to come. There are certain growth anomalies here where we have to address not only the condyle, but other parts of the mandible. Like here we see, it's a case of hemimandibular hyperplasia, in which there's a huge condyle, ramus, and the right side body itself is so huge. And there's a massive cant in the occlusion and disproportionate angulation of the maxillary mandibular complex. So here we went for high condylectomy. We went for an inferior border osteotomy, preserving the neurovascular bundle intraorally. Once it all healed up, after a month and a half, we recalled back the patient, counseled him, made him understand his guardians. We went for a Lefort 1 osteotomy and ramal osteotomy on the left side, fixed a distractor. As you can see here, fixed a distractor, and we started doing simultaneously maxillomandibular distraction canting correction. If you see in this video how the distractor is opening and the distracted segment intraoperatively can be checked for its freeness and movement subsequently. Now this is the post-distraction status, and this is how the individual went back subsequently. Now coming to trauma, fractures are the bread and butter of any maxillofacial surgeon, without doubt. Now once we go for this trauma, various kinds of approaches are there as far as subcondyle is concerned. But my personal preference is anterior parotid transmasseteric approach in majority of the cases where I find that there is complete safety to the parotid gland. It is very user-friendly to the facial nerve, minimal scarring because it is hidden at the retromandibular region, and there is minimal loss of function and spasm of the muscle because we are using the natural defect at the posterior part of the pterygomasseteric area to enter the area. Exposure is very good. If the plane dissection is correct, the reduction and the fixations come out very well. We have used 3-dimensional plates. They are very good in using and very user-friendly. The fracture segments are very stable. Now in this, we have also done a case where the condylar stump has been badly comminuted due to the trauma. We have used the segment of the mandible itself, the posterior part of the ramus, and we have created a ramal condylar unit with the help of distraction osteogenesis, which can be very beautifully seen in this orthopantomogram. If you see, this is the distractor. Once the condyle is removed, the osteotomy cut is made, the distractor is used. Now the distraction at various phases, though we are not supposed to take so many radiographs, but for purpose of academics, after taking consent of the patient, we did the radiographs, and you see that after 40 days, the consolidation which can be seen. We remove the distractor after 55 days, and this is the bone which has formed here, very stable bone, and this is the patient post-operatively with good interincisal opening and good occlusion. In another case, there was a combination of trauma as well as replacement of the joint. This lady had a bilateral subcondylar fracture and a parasymphysis fracture after falling from a two-wheeler. The right side fracture was a classical subcondylar fracture, but left side fracture was a split and comminuted fracture. So on the right side, we went for Mayer's technique of fixation of the condylar fracture. On the right side, we removed the, on the contralateral side, we removed the comminuted piece, we replaced the joint, and this is how the individual is post-operatively, and a balanced joint both sides, and you can see her function doing so well. I don't know whether her speech is coming or not. You can see her occlusion. She is doing quite well. Now, as for the grafts, as we have said before, we use grafts from vicinity in the form of coronoid processes. We use the graft from posterior border of ramus, a graft used from ankylotic mass, which I have not personally used ever from ankylotic mass. Now you have graft from iliac crest. I've used that. Costochondral graft, definitely we have used that. I've not used any fibular vascularized or non-vascularized graft for TMJ reconstruction. Neither I've used a sternoclavicular graft, nor I have used a metatarsopharyngeal joint. I feel personally they are more of theoretical rather than practical, because it is a lot of disability will come in the secondary joint side. As far as the joint replacement is concerned, I will just touch on it very shortly, because the next speaker Dr. Mercury will be talking on the joint replacement. Just a basic understanding that they are either custom made or stock. In the world presently, there are 4 companies which are developing the joint. I have personally used the Biomet microfixation system in 41 joints and 36 patients. And I have used it in fractures, congenital anomalies, in arthritic condition, ankylosis, in failed TMJ reconstructions of other kind, in case of avascular necrosis, post-trauma, neoplastic conditions benign, loss of condyle due to any reason. There are many indications as far as children and adults are concerned. I'll not go into too much of depth into that, but definitely I'll sum up that when to reconstruct that when it is a refractory arthritic condition in the joints ankylotic, where there's a failed graft and there's loss of vertical mandibular height due to any reason or loss of occlusion. We have published a paper on this with a good amount of reading on that. And our take is that it allows immediately post-operative physiotherapy, no donor site morbidity, decreased surgical time, mimics normal anatomy, maintenance of stable occlusion, can correct a lot of other simultaneous conditions like abruptognathia, retrognathia. But certain disadvantage is that the first one is that surgical skill has to be good here. Everybody may not be able to do it initially. They have to increase their skill before they touch this particular thing. Cost, of course, wear and tear, heterotropic bone formation, possible need of revision, though in none of my cases, I've had a follow-up of 6 years now. None of the cases required. And there's no growth potential in this. So in case of very young adults, we may have to repeat it. So our inference is that TJR is superior to many other forms of reconstruction of the temporomandibular joint. Before I conclude, I'd like to show a very short video of 2 minutes on the exposure of ankylotic joint and subsequent reconstruction, because what we see talk, we must see also, we must show also. So here we open we are opening the joint, and we see that so-called ankylotic and distorted joint is exposed. Here you can see the cleft between the ankylotic mass and the zygomatic infratemporal area. I prefer to use a curved osteotome or a straight osteotome, very thin size, to mobilize the joint, then do the osteotomy cut at the prescribed distance from the ankylotic area. Once this is there, completely cut, then we mobilize the ankylotic mass completely in toto as it is seen. And if the joint is mobilized well, the full mass comes out from the infratemporal fossa. There's no need of subsequent cutting. Then the coronoid is removed as per the indications in size, that is pre-operative assessment, the affected side, and many a times from the contralateral side also. There's a huge coronoid. The coronoid is being removed, now opening the submandible area and preparing for the site for the joint to go in. Once the dissection is complete, we open the joint, we open the ramus, and we prepare the ramus by flattening it so that there is minimal fulcruming or rocking of the condylar processes. The infratemporal fossa is prepared, the stent is placed, and it is marked, and pre-adjusted holes are made. Once this is fixed and the condylar stent is checked, then this stent is removed and the actual fossa is placed. The condylar component taken out, pushed into its place, as we can see, and fixed rigidly. And you can see the movement, so beautiful movement subsequently. And what does the future hold as far as the surgeries are concerned, or TMDs or TM joint replacements are concerned? Very soon we'll start having tissue engineering and nanobot technology, which is in a trial phase in certain countries. Human gene therapy, definitely it will come through, because all diseases and disorders will be treated one day by genetic therapy. In conclusion, I would like to say that the concept of understanding the TMJ disorders and management have changed drastically in many years. Multi-speciality involvement is mandatory. Surgery, which was considered risky once, has become more beneficial due to developments in skill, equipment, and anesthesia. Some surgical procedures have become redundant, but some are being still followed. And long-term multicentric studies are very important, which are not there too much, at least in certain countries. But one thing is very imperative, that there are requirements of refinement in reconstructive procedures and minimally invasive procedures at the call of the day. Now, drastic situation requires drastic measures. This is how we are operating in the Armed Forces OT. I'm sure every one of us are doing like that. Thank you, ladies and gentlemen, for a patient hearing. And I thank the Association of OMFS, Tamil Nadu and Puducherry branch once more. Jai Hind.
Thank you, Brigadier Dr. Roy Chowdhury, sir, for that enthralling and awe-inspiring presentation on open joint surgery. Can we have the next speaker, please? The next speaker of the day is a surgeon whose name is quite synonymous with the temporomandibular joint. Yes, it is none other than the exceptional Professor Dr. Louis G. Mercury, who will be enlightening us this day on his personal experience concerning temporomandibular joint internal derangement. Over to you, Professor.
I've been asked to do a presentation on my thoughts about internal derangement. This is where I live and work, and this is my disclosure. The term internal derangement actually started in 1826 by Sir Astley Cooper. He described an internal derangement of the meniscus of the knee, and it was reported in this volume. It never really took hold with the temporomandibular joint until Annandale in 1881 wrote a paper where he described reducing a disc for a patient. But then it sort of went to sleep again until the early 70s, when a dentist by the name of Bill Farah and an oral surgeon by the name of Bill McCarty came along, and through their organization, the Normandy Study Group in Birmingham, Alabama, said that they think that they have discovered the answer to temporomandibular joint problems, and it's called internal derangement of the TMJ, or disc displacement, that all problems associated with the temporomandibular joint can be related to displacement of the articular disc. In the late 70s, I spent a week with Clyde Wilkes. This is Clyde, up in Minneapolis, and watched him do arthrograms, because we didn't have MRIs at that time, and do surgery. And Clyde's whole idea of internal derangement was that it was the basic pathological entity. In other words, it was the diagnosis for the TMJ pain dysfunction syndrome. And if you didn't take care of it, if you didn't manage it or treat it, you got progression to an advanced degenerative stage of the disease. And you're all familiar with the Clyde Wilkes classification. But the wide acceptance of an idea is not proof of its validity. Because when you only have one idea or one thought or one diagnosis for every problem that comes in, you only have a hammer. Then every problem looks like a nail. So whether you have a screw or a nail or whatever, you're going to hit it with that hammer until you make it fit. And that became the problem. We started seeing patients who were being operated just because their disc was displaced. Here's a good example of a patient who has a anterior displaced disc. I think everybody will agree with that. Anterior displaced disc. It's even out of shape here, right? This patient has no symptoms. Actually, this is me. This is my MRI, all right? I've had anterior displaced disc probably for my whole life. I've never had a temporomandibular joint problem in my life. So what percentage of patients have anterior displaced discs? Well, according to this study, or these studies, in cadavers, again, where you don't know the history and all of that, it was 56%. But when you looked at asymptomatic volunteers, and here's 4 of many studies, that looked at asymptomatic volunteers. It's 23 to 35%. So just because someone has an anterior displaced disc and they have maybe a headache or they click or whatever, doesn't mean that they have pathology. There's another study, a more recent study that just came out in the Spanish journal. 30.5% of asymptomatic volunteers. So about 1/3 of the people walking around have anterior displaced discs. And so what we've done because of the MRI is we've tended to overdiagnose this displacement. And making it the diagnosis, and us having the hammer of surgery and that being the nail, we have now all of a sudden decided that this is something we have to treat. But what we really need to do with the MRI is base, as we do all of our surgery, not on the imaging, but on the clinical relationship of signs and symptoms to the pathology. This is a paper that came out recently that said there were no factors associated with concomitant presence of arthralgia in patients with disc displacement with reduction. So what's going on? What do we think? This is what I think is going on. The disc displacement represents the extremes of a normal variation. Okay, these are variations of normal. 30% of the population have this problem. Internal derangement is a sign. Okay, it's a sign, not a diagnosis. Inflammatory changes in the joint capsule, synovial tissues, and retrodiscal tissues are likely more important for the development of symptoms. Synovitis. And so we're ending up with what orthopedic surgeons call biomechanical instability. We have trauma to a joint, we have overload to the joint, and we have maladaptive responses that Chuck Milan talked about back in the 90s. This all leads to an inflammatory cascade. This inflammatory cascade releases cytokines, the alphabet soup of inflammation, leading to synovitis. Synovitis leads to impaired lubrication and nutrition of the articular cartilage. This leads to impairment of biomechanics, which leads to further increase in synovitis and limited mobility. Now, where does the limited mobility come from? The limited mobility comes from two sources. Number one, when you get a synovitis, and if you look at this joint with all this inflammation in the retrodiscal tissue, you're going to get bleeding. When you get bleeding into the joint, you're going to get the formation of adhesions, or what we call adhesions, scar tissue, basically. So in the early stages, you get these adhesions that can easily be broken up using arthrocentesis. But when you get to the later stages, we have more limited mobility. That's where arthroscopy is helpful. So arthrocentesis and arthroscopy, used properly at the proper time, will help us resolve these patients' problems. So this is Howard Israel's work. Howard and I have been talking about this subject for months now, that internal derangement of the temporomandibular joint is not a disease, but a non-specific sign of tissue failure, leading to biomechanical instability of the joint, just like every other joint in the body. This tissue failure is usually caused by TMJ mechanical overloading, leading to inflammatory and then degenerative changes. Intra-articular changes associated with internal derangement can also be caused by systemic arthropathy or localized atypical arthropathies involving the temporomandibular joint. So we're talking here in terms of a systemic arthropathy, something like rheumatoid disease or JIA, or localized atypical arthropathies such as idiopathic condylar resorption, which I believe is part of the spectrum of JIA. So where does the disc fit? How do we fit the disc into all of this? Because the disc is there, and it is part of this biomechanical instability. How do we fit this in? Well, this is a very simple equation. Joint plus muscles equals motion plus function. I think everyone will agree with that. So impairment of condylar movement is the result of the development of adhesions within the joint capsule and Hilton's law. Now, if I was standing before the audience, rather than sitting here in my office at home, I would ask this question: how many people know what Hilton's law is? And if there were 100 people in the audience, I would venture to guess maybe 5 people would raise their hands. Hilton's law is an orthopedic law that states that the nerves that innervate a joint also innervate the muscles that move that joint, as well as the overlying skin. And for the temporomandibular joint, it's obviously the trigeminal nerve or cranial nerve 5, because 75% of the innervation of the temporomandibular joint is via the auriculotemporal nerve. The other 2 branches, the deep mesenteric and deep temporal nerves, are part of the trigeminal nerve as well. Now, what is Hilton's law? Why is it important? Well, it's self-protection law. If you've ever injured your knee or your ankle or your elbow, you'll notice that the muscles that move that particular joint tend to tighten up. They get sore. I have a bad knee, okay? Muscles in my calf and muscles in my thigh hurt. Not because it's the muscles that are the problem, it's the joint that's the problem. And what it's doing is preventing me from using that joint. Well, the same thing happens with the temporomandibular joint. If there's an inflammatory response, if there's this biomechanical instability, the disc is out of position and you have an inflammatory response, okay, then you're going to kick off Hilton's law, and the muscles of mastication will react to it. So as a sort of an example, in the UK, they call this a sleeping policeman speed bump. So what you have in the temporomandibular joint is the disc acts as a speed bump. And if the joint is inflamed, it inflames the joint even more for the patient to have to jump over this disc or this speed bump, as opposed to the nice smooth movement that you would have down a road like this where there is no speed bump. So if the bump is gone, if the bump is moved forward by either an arthrocentesis, removing the small adhesions, or an arthroscopy, lysis and lavage, where you move the disc forward, you have a nice smooth function. So mobilization of the disc is more important than reducing the disc into its position. Disc function is more important than disc position. I repeat that because that's my whole thesis here, is that disc function is more important than disc position. There, if someone's going to ask the question about, well, when would you ever reposition a disc? Well, interestingly enough, there's really scarce evidence that reducing the disc actually does resolve temporomandibular joint problems. And honestly, I probably did over 400 disc repositionings after visiting Clyde Wilkes in the late 70s and early 80s. Followed those patients for 8 years, and maybe 20% of those patients did well. The rest of them did poorly. So I'm not a big fan of disc repositioning. Also, I've seen very little long-term data that the disc stays in the position that you place it when you do a disc repositioning. And then many of these discs that I've seen, there's no way you could reposition because of the shape of the disc. So recapturing the disc to me is not a reasonable option. My surgical procedure for disc displacement where I can place a local anesthetic in the joint and takes 75% of the patient's pain away, and the disc is stuck, or it appears to be a speed bump that I cannot get out of the way arthroscopically. I will do a discectomy. I think we have enough data now from a number of people, mainly in the Scandinavian literature, but in some of our own literature here in the United States. Mike Maloro has done some really good stuff with that at the U of I. That discectomy does seem to work well for these patients. And yes, they will develop some changes in the joint. They will develop some joint noise, but those patients seem to do better than patients that certainly ones that I did disc repositioning. So recapturing the disc either surgically or with orthotics, anterior repositioning splints and the like, it seems like an unreasonable option to me. And finally, this is a haiku from Ed Selden at Harvard. He wrote back in 1983, which holds true today probably more so than ever. When your disc is at risk, choose carefully who you appoint to fix your joint. I want to thank you for the invitation for doing this presentation. These are some of my final pearls on this. Internal derangement of the temporomandibular joint is not a disease, but a nonspecific sign of tissue failure leading to biomechanical dysfunction of the joint. And then once again, disc function is more important than disc position. This is, for those of you who've been to Chicago, or this is a sculpture by an Indian sculptor called Cloudgate. We call it the bean. I call it the disc. Probably the best place for a disc is sitting outside in somebody's yard. So thank you again for the opportunity to do this presentation. I look forward to any questions that you may have, and I hope everyone is staying safe and healthy through this very difficult time. Thank you.
Thank you, Professor Louis Mercury, for an enlightening presentation on your personal experience in managing temporomandibular derangement and your perspective of how disc function is more important than the disc position itself. And I'm sure that all the participants have highly benefited from all the scientific presentations. And dear participants, kindly note, please fill in the feedback form to receive your e-certificates. And the link for the feedback form will be posted in the chat box at the end of the session. And we have received so many questions from our lively and inquisitive participants. And now let's move on to the most awaited part of the conference, the panel discussion, where all your questions will be answered. And I invite Dr. Jimson and Dr. Vandana Shenoy to moderate the panel discussion. And Dr. Jimson, Honorary State Secretary of the Association of Oral and Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch. He heads the Department of Oral and Maxillofacial Surgery and is the Vice Principal Research at Tago Dental College and Hospital, Chennai. His drive to educate and empower our fraternity has brought us to this point of organizing an international web conference, the first of its kind. And thank you, Jimson sir, for being the backbone of all these web conference and the webinars. And now about Dr. Vandana Shenoy.
To join Dr. Jimson, we have a bright and cheerful women maxillofacial surgeon who has numerous accolades to add to her credit that range from academic achievement to professional merits. She is none other than the lively Dr. Vandana Shenoy. Dr. Shenoy received her undergrad and postgrad degrees from Bapuji Dental College and Manipal Dental Colleges, respectively. She continued on as an academician at A.B. Shetty Memorial Institute of Dental Sciences, Mangalore. She then went on to pursue her MFDS RCPS at the Royal College of Physicians and Surgeons of Glasgow. She has also been accredited as a fellow of International Board for Certification of Specialists in Oral and Maxillofacial Surgery. She currently occupies the position of professor at Thai Nokambigai Dental College. While being active in her role as a professor at her institution, she has also authored numerous articles of credit in international journals. She is also one among the reviewers for IGOMS, JCDR, and Curious Journal of Medical Sciences. Her areas of interest cover maxillofacial trauma, maxillofacial pathology, dental implantology, and the temporomandibular joint. Over to you, ma'am.
Good evening and good day to all. Am I audible?
Yeah, you're audible now.
Yes, ma'am.
Good evening and good day to all. It is a true honor for me to moderate today's panel discussion. At the outset, let me thank the organizer and AOMSI Tamil Nadu and Puducherry branch for giving me an opportunity. I request all the eminent speakers of the day to be online now, and we welcome them for all the long-awaited panel discussion. We are happy to announce that we have 750 registrations today and more than 500 participants are online now. And let Dr. Jimson and I quickly introduce all the panelists to you one by one. Jimson, sir.
Yeah.
Over to you, Jimson, sir.
Yeah. Thank you for the introduction. Yes, now it is my privilege to introduce Professor Louis Mercury. He's a cum laude graduate of Georgetown University School of Dentistry, Washington, D.C. He received his certification and Master of Science degree in oral maxillofacial surgery from the University of Illinois, Chicago Medical Center. Dr. Mercury presently is a visiting professor in the Department of Orthopedic Surgery at Rush University Medical Center, Chicago, and also an adjunct professor in the Department of Bioengineering at the University of Illinois, Chicago. He is the president of UIC Institute of Biomaterials, Nanotechnology and Regenerative Medicine, and a clinical consultant for TMJ Concepts, Ventura, California. He is the uncrowned king of alloplastic TMJ replacement. We are fortunate to have you here on the panel, Professor. Welcome.
Thank you. Thank you very much.
Welcome.
The next speaker of the day
please, yeah,
is Dr. Gary Warburton. The Warburton trained in oral and maxillofacial surgery in the United Kingdom and completed his training at the University of Maryland, Baltimore, United States of America. He earned his dental surgery and medical degrees from Manchester University in the United Kingdom, where he obtained numerous academic honors and awards, including the Alpha Omega Prize for Clinical Excellence. In addition to his oral and maxillofacial surgery training on both sides of Atlantic Ocean, he has completed a fellowship in clinical research at the National Institute of Health. He has numerous publications. He is the pillar of training in the field of TMJ arthroscopy and total joint replacement. He runs the mini residency course to train the residents on TMJ surgery. Presently, he is the Associate Professor, University of Maryland School of Dentistry, University of Maryland Medical Center, and R. Adams College Shock Trauma Center. He is also a Division Chief, Oral and Maxillofacial Surgery, University of Maryland Medical Center, Chief on the Maxillofacial Trauma, Sinai Hospital, Chair of the TMJ section of SORG North America, Clinical Consultant for TMJ Concepts, and also Adjunct Associate Professor, Amrita Vishwa Vidyapeetham, Amrita University, Kochi. It is an honor to have you on our panel, sir. Welcome, sir. Welcome, Dr. Professor
Good evening.
Gary.
Thank you for having me. It was an exciting presentation of speakers.
Thank you, sir.
Thank you. And now it's my privilege to introduce the next panelist, Brigadier Dr. S.K. Roy Chowdhury. He is alumnus of Dr. R. Ahmed Dental College and Hospital, Kolkata, and MDS from University of Mumbai from the Advanced Specialist course. And he did his OMFS in compact surgery from AMFC, Pune. He is a recipient of a number of academic awards and has been a recipient of Commendation Medal of Chief of Army Staff twice and the GOC Northern Command once. He has experience of more than 2.5 decades in advanced craniomaxillofacial surgical procedures and one of the pioneers in TJR, arthroscopy, and open TM surgery in India. Presently, he is a professor and consultant OIMFS at a tertiary care teaching combat care health setup in Western Sector, of the country. He has numerous publications in various national and international journals of repute. It's our pride to have you on our panel, Professor S.K. Roy Chaudhary.
Thank you so much. Thank you.
Next panelist is Dr. Nehal Patel.
Yeah, please proceed.
Shall I proceed, sir? They have not changed the slide.
I have.
Dr. Patel has completed his master's in oral and maxillofacial surgery from A.B. Shetty Institute of Dental Sciences, Mangalore. He did his fellowship in cleft and craniofacial surgery from Mangalore. He did his mini residency in TMD arthroscopy and total joint replacement from USA. He worked as a consultant cleft and craniofacial surgeon in BSES-MG Hospital. He is currently working as a director at ABMSS Cleft Project in Surat, Gujarat. He is our Secretary of Indian TMJ Society. Welcome, Dr. Nehal. Glad to have you here on the panel.
Thank you, Vanna. Thank you, Jim.
Thank you, Nehal. Yeah, now it's my privilege to introduce the next panelist, Dr. Chetan Hegde. He is a prosthodontist. He has completed his BDS and MDS in prosthodontics at A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, and he is currently working as professor and is heading the department in the same institution. His areas of interest include full mouth rehabilitation, TMJ disorders, occlusion, aesthetics, and implantology. He has authored more than 100 articles in various national and international journals. He has pursued PhD in the Faculty of Dental Sciences from NITE, the deemed university. He is an endurance athlete, having completed one full distance marathon of 42 kilometers and 4 half distance marathons. Welcome, Dr. Chetan Hegde, to the program.
Thank you, Mr. Dr. Jimson. It's been absolute pleasure to be amongst oral surgeons. It's been a great platform. Thank you very much.
Thank you.
Now, next panelist is Dr. Vishal Bansal. It is my privilege to introduce him. He is a professor and head of the department of Sabrati Dental College, Swami Vivekananda Sabrati University. He has a keen interest in TMJ disorders and alloplastic joint reconstruction. He also has a number of national and international publications and numerous publications on TMJ. His latest publication explains the role of intra-articular injection and platelet-rich plasma and arthrosynthesis in TMJ disorder. And we are pleased to welcome you, sir, on our panel.
Thank you, organizing committee. Thank you all.
And next speaker of the next panelist is Dr. Aishwarya Nair. She is the first maxillofacial surgeon in Mumbai and amongst the first few in India to acquire the fellowship and advanced training from USA in TMJ arthroscopic surgery. After her MDS, she has pursued TMJ surgical mini residency on TMJ arthroscopy and joint replacement from New Jersey. She is also trained in McCain TMJ surgical arthroscopy, trained by Dr. Joe McCain at Miami, Florida. She is presently the assistant professor in D.Y. Patil Dental College and Hospital, and she is a founder and co-owner of Face and TMJ Crafters. She is exclusively practices maxillofacial surgery and management of TMD and orofacial pain in Mumbai, Thane, and Navi Mumbai. Welcome, Dr. Aishwarya.
You're muted, Dr. Aishwarya.
Thank you, ma'am. It's an absolute pleasure to be a part of this.
Yeah. Yeah, I think We had wonderful presentations. Now it's given a time. There are quite a few questions which were asked in the question and answer section, which have been answered. Many have been answered by the panelists themselves. But from the presentations, we have few questions. I think we can have a productive discussion. I will direct the first question to Dr. Aishwarya Nair, who started off the presentation today. Is there any role for any biomarkers in identifying the severity of the TMJ disease process?
Yes, sir.
Can you enlighten the participants, please?
Yes, sir. So there are various biomarkers, actually molecular biomarkers and bone biomarkers, which are cytokines and MMTs, etc., which are elevated in TMD patients. But in clinical perspective, if you see, I'm not sure if it is very significant in the early stages of the disease. I think it is more significant to diagnose the progression of the late stages of the disease. I think early, it is much more clinical examination and followed by radiological examination is more significant than using biomarkers, though there are many biomarkers which are increased and do suggest greater evidence in TMD patients than in normal joints.
Thank you. And Brigadier S.K. Rai Chaudhary, you would like to add anything to this?
As far as my experience is concerned, we are using for the last couple of years back biomarkers to make out the inflammation and the immunoglobulin markers specifically for TMJ. But honestly speaking, unlike the larger joints in the body, like I've had a complete discussion with the orthopedic surgeons in our centers, they are not very conclusive. That is my personal opinion. I don't know what the other panelists may say as far as their experience is concerned, because we realize that there is some kind of other inflammation going on in and around the head and neck area. So the biomarker result may not be up to the mark, which may not be actually accurate. Other panelists may kindly chip in their thought process.
Yes, Professor
Yes,
Louis.
Professor Louis.
Yeah, thank you for your comments. I have been working with the orthopedics department at our institution, and one of the anatomists there is very interested in biomarkers for osteoarthritis. And so he has a project going where he's looking at the various cytokines, as Dr. Nair has talked about. And unfortunately, what's happened is that when you do a Western blot on all of this, what you find, it's all over the place. So you can't really come up with a single biomarker. So what they're looking at now is trends, okay, across multiple biomarkers. But then those vary from patient to patient. So it's a very complex thing. What I would like to see done is someone who's doing a lot of arthrocentesis to look at the viscosity of synovial fluid. Okay, do some viscosity studies, because I think if you take the different classifications of the Wilks classification and you do Wilks 1s, you're going to find a completely different viscosity of the synovial fluid in a Wilks 1 than you would, let's say, in a Wilks 3 or 5. So I think that would be an interesting study to do, and I think that would probably be the data that we would get from something like that would probably be more important than looking for biomarkers. But that's that's just my thought.
In fact, I completely agree with Dr. Mercury, because we had also tried to aspirate the synovial fluid from the TMJ before we did the arthrocentesis. But majority of the time it was mixed with blood, which is what natural. And maybe the transportation to the biochemical lab may not be up to the mark. So the resultant findings were not very conclusive.
Thank you. Thank you.
One more
Dr.
clinical.
Gary, your thoughts? Gary, your thoughts? Am I audible?
Sorry, yes,
Yes, sir.
I was on mute. So I agree with Lou that we've seen from research, basic clinical research, there's a soup of inflammatory mediators that has been identified in the joints of any inflammatory condition within the joint. The volume of fluid is very small. It's no more than 2 cc's at most, and I've tried to aspirate it and send it off for cytokine analysis. I also want to comment on the viscosity suggestion. I think that's very relevant. We know that the inflammatory soup degrades the hyaluronic acid, which is one of the main components that affords viscosity to synovial fluid, and the inflammation degrades it. So the lubrication system fails inside the joint. The question is that any different in a Wilks 2 versus a Wilks 4 and 5? So I think that's a relevant area to look at.
Professor Vishal sir, you would like to add on to this?
Basically, IL-1 and IL-6 and 8 are highly increased in rheumatoid arthritis, where IL-17 are increased in psoriatic arthritis. And there are some of the studies which shows in unsuccessful cases also, they found to be increased level in unsuccessful cases of arthrocentesis. So truly cytokinin and viscosity is one of the important factors to diagnose the early internal derangement disorder.
Thank you, panelists. The next question will be more clinical. What is the rationale behind the removal of third molars in managing the temporomandibular joint problems? It seems to be the first step followed by many. Does it have any scientific background or is it overrated? Dr. Aishwarya?
I feel it is overrated.
You are the opening batsman today.
Yeah.
Okay. I feel it is overrated. I really feel that though the symptoms of third molar pain and TMJ pain or the other symptoms may overlap, but I don't feel third molar is really a cause of TMJ pain. There are two scenarios where an erupting third molar with an eruptive force may cause some amount of crowding or malocclusion, which I think the joint actually adapts to. And the second scenario is where the third molar surgery has been a long surgery and the mouth has been open for a long time, and there's some amount of micro trauma where in a person who has some pre-existing TMJ problem, there may be aggravation to that problem is what I feel. I don't think it can be a cause to TMJ pain as such. I think Gary sir or...
Can I say something?
Yes, sir.
Yeah, so removal of third molar in case of actual internal derangement can worsen the condition rather than solving it. Say patient has, it is like if you have twisted your ankle while walking on a road and then you keep on running on the same ankle for another 1 month. So if say patient has an anterior disc displacement with reduction, it is an inflamed joint. And then if you keep the patient mouth open for half an hour for removal of the third molar, that disc displacement can get stuck and become anterior disc displacement without reduction. So I think it's overrated. What do you say, Gary?
It's overrated. And I think what it boils down to is an accurate diagnosis, right? So you have to be able to accurately diagnose the muscle disorders and the joint related disorders, and thereby eliminate the third molar as an overlapping condition. I think it's overrated. I'm not aware of any evidence that suggests that third molars increase the rates of internal derangement. I think myofascial disorders, if we're talking about TMD broadly and including the muscle disorders, then that's a possibility. If you have pain from a third molar, then I think that may, in some people who lack adaptive capacity, that may be enough to create some myofascial symptoms, but it's certainly not going to cause internal derangement.
Can I make one comment?
Yes, sir.
Yes, please.
In a study that we did many years ago, we had a TMJ facial pain center when I was in Virginia. the number one misdiagnosis by dentists who would refer patients in to our TMJ clinic was pericornitis. Okay, so Gary is correct. That's the link. And I think Nihal also has a very good point there, that patients who have disc displacement or synovitis, I think the term is better used, synovitis. But if they have a synovitis going on and you sit and crank their mouth open for a half hour to get their wisdom teeth out, those patients are going to have a problem afterwards. So there's the relationship there.
Okay, any other panelist would like to add?
Can I say something, Dr. Vandana?
Yes, sir.
Yeah, I think all your opinions are right when you relate it to the lower third molars. Okay, there is no connection to TMDs with the lower third molars. But when the upper third molar is too much buccoverted, I feel there is a relationship to the TMD development because of the buccoversion, the patient tries to avoid biting in the centric relation. They tend to bite more laterally towards the buccoverted tooth. So the occlusion changes. That can be a reason for the microtrauma leading to TMJ internal derangement. That's my practical experience, but as you asked, there is no scientific evidence. So in those cases, I prefer to extract buccoverted upper third molars. But lower third molars, no, there is no connection. That's what I feel.
May I say something?
Yes, sir. Yes, sir. Roy, sir.
I very much agree with doctor here, because if you see the upper third molar, especially which are impacted, and if there is chronic pericornitis, there have been studies which say that infection spreads through microspread of the infection through the partial spaces and may result in spasm of the lateral pterygoid muscle. So that may cause a simulated pain or a TMD kind of thing, which may not be actually true. But otherwise, as far as the lower one is concerned, there is no anatomical or physiological link with the temporomandibular joint to create problem.
Correct.
So I still remember maybe 15, 20 years back, I had heard in one of a conference that people have started doing pterygoid disjunction to ease the pain of TMDs. It had come in a big way, but it fizzled out on its own because of many reasons. So that's it.
Have any other panelists have experience with the pterygoid disjunction?
It is helpful, no doubt.
Is it minimal invasive surgery for internal derangement? Do you think so? Vishal, sir?
Yeah, definitely it is helpful because it basically releases the lateral pterygoid and continuous anterior medial pull of the condyle. It will reduce and creating a more interarticular space. So even my few more than 10 cases, I have found it's very helpful procedure.
Yes, Dr. Varghese Mani from Kerala is a big believer of this system. I think he has done a big study, large study. Yes, and he has consolidated his findings that the fracture of the lateral pterygoid plate relieves TMD pain. That's his conclusion.
It is published in the Asian Oral and Maxillofacial Surgery Journal.
Exactly.
And I think Dr. Rohit Sharma also has done the similar study in 2012, which is published in our national journal.
Okay. And
what is the role of ultrasonography in diagnosing temporomandibular joint problems, Dr. Nehal?
Personally, I don't have actually any experience, but as far as literature is concerned, there is evidence that you can diagnose effusion, joint dynamics, but I am not sure whether you will be able to diagnose any particular condition with the USG. What is your experience, Professor Luis, with USG?
Sir has muted. Professor Luis has muted.
Professor Dr. Louis?
Yeah, sorry. The only thing I've seen in the literature that makes sense using ultrasonography is, as you said, it's not a diagnostic tool in terms of disposition and things like that. was some work done by some colleagues in the Czech Republic, Dr. Mahon and Levotra. And what they showed was that it was useful for positioning your needle when you were doing arthrocentesis. That was about the only thing that they showed that it was good for. So I've never seen that it was useful for making a diagnosis of this displacement or anything like that.
Can I add something, please?
Yes, sir.
We have had a project in which we did about 100 odd cases of TMD for ultrasound. There are a couple of problems associated with it. First of all, they didn't have a media to do it, so they filled up a glove with fluid and then they did it through that. So we compared it with colored Doppler, and we realized that colored Doppler actually is giving you almost maybe 50% plus information over the disk. Can be tried by the panelists sometime, colored Doppler. Otherwise, ultrasound may not be so useful.
Is it helpful to see the entry port for the arthroscopy or arthrosynthesis, sir?
I have no experience in that. You mean basically USG guided?
USG guided.
Like they do it in the abdomen, because abdomen is a big cavity actually. It's much simpler for them to do. As it is, the TMJ complex itself is so small, maximum 1.5 to 2 ml of fluid. The compartments are also so minuscule. So if you have a probe of a ultrasound there, along with your needles and your arthros, not very easy to work, I presume. So abdomen may be a good area because it's a huge area. That's why they do a lot of ultrasound guided biopsies and all for the liver, spleen, and all those things. But I have no experience in that.
Thank you, sir. Jim, sir?
I can comment on the
Yes,
ultrasound
sir.
for
Yes, sir.
arthroscopy.
Please.
I agree. I think the probe would be too much in the way of what you're trying to do. There are some mechanical devices that are being developed that aim to help localize the puncture site, and particularly with second cannular insertion using vectors. Arthroscopy, for those that have tried it, it's tricky. It's a very sensitive technique. It takes time to develop neuromuscular memory to be able to access the joint predictably and safely. So I think ultrasound for accessing and facilitating entry with either needle or cannula, I think it's going to be too much in the way.
Yeah, thank you, Gary.
Thank you, sir.
And now, Dr. Chetan, it's a question for you. Is there any role for T-scan in diagnosis and management of TMD?
Well, it basically tells you about the occlusal contacts and the forces used, the timing of the contacts. With respect to internal derangement, I really don't see much of a diagnostic value with T-scan, because it gives you more with respect to what is the timing of occlusion. Is there any initial early contact? What is the amount of load, occlusal load being applied, and so on and so forth. So it may not be much of a value with respect to diagnosis.
Thank you.
What, Chetan sir, one more question.
Yes, please.
Yes, sir. What is a jaw tracker and jaw vibration analysis in diagnosis of TMD?
Jaw tracker basically tracks the way the jaw moves. You know, it's got a receptacle. So you add these things onto your. It basically tracks the way your jaw is moving, whether the movements are uniform, slow, or is there any hindrance coming in the way. For example, if there is a disc displacement, then it shows a deviation in the movement of the jaws and things like that. It is of some diagnostic value. The other one you asked, what was it?
Joint vibration.
Yeah, there is joint vibration analysis, which is of some help in analyzing what are the I mean how the movements are taking place, what are the in doing vibration analysis. Basically, they act as adjuvants, right? Ultimately, you need to take these along with your clinical acumen, along with the advanced diagnostics like MRI to confirm any diagnosis.
Do you get MRI for all the internal derangement patients, Dr. Nehal?
No, it's not as far as see. It's a more of a clinical judgment. When you know clinically that there is internal derangement, and when you are starting some conservative treatment, I don't get for all the patients. If I am planning, say, arthroscopy, then yeah, I mean, I get it only for the insurance purpose, because sometimes it is very clear and diagnosis, and you don't require, because anyway you are doing a diagnostic scopy. But to put it on a paper that this is a diagnosis and you justify your procedure for the insurance, you have to get MRI. I mean, so not all for all patients, of course.
Professor Gary, what is your opinion? Do you ask MRI for every patient?
No, is the answer. Those that well, back up a little bit. So my practice is tertiary referral, but some patients come to me as the first provider. The majority of those are not surgical candidates. So I don't get the MRI scan unless I'm planning on doing some surgical intervention, arthroscopic surgery. The reason I do it is partly, as Nehal said, for insurance, but the insurance providers also know that disc displacement is present in 35 to 38% of the population, right? So they're smart, they know that. You need to support that with all the clinical information that goes along with it. The biggest reason I get it actually is medical legal here in the US. And so for surgical cases, most of the time, yes, I will get an MRI scan.
Nehal, in your presentation, I think you mentioned about a questionnaire that you give it to the patient. So, am I right?
That is modified version from Gary's questionnaire, actually. I mean, what they have prepared for. So I have modified for our scenario in Indian version. It's a 4-page questionnaire, where actually when you give it to the patient, it reduces your time to take a history, and there are questions which you may forget to ask when you are clinically or asking the patient. When they fill out, when you see that form, you come to know whether that patient is actually of muscular, I mean, it's a real ID or there is a muscular problem. If they are muscular problem, I don't have to spend much time with them. I mean, you can just send those patients, because anyway, I'm not going to do any procedure for them. That's the reason I have made that form. And it helps to give a post-operative. So in that form, we usually mention Wilks classification. So after scopy, we take a VAS scale every week, 1 week, 15 days, 1 month, 6 months, 1 year, 2 years. So it gives you idea that what is actually happening with your patient when you do some procedure on that. That's the reason. I mean, it's Indian modification from actual Gary's form.
Mr. Luis,
Yeah,
please.
First of all, I'd like to say that I agree 100% with Gary, having been in a tertiary practice and do exactly what he said. But I think the point that also has to be made here, or comment that has to be made, is that every patient who comes in with signs and symptoms of temporomandibular joint problems deserves some sort of imaging. Because over the 50 years that I've been dealing with this, I have probably a dozen or more patients who have had something seriously wrong that was missed because no image was ever made by the initial physician or dentist that saw that patient. And I'm talking tumors. Okay, so you get a 76-year-old woman that comes in with signs and symptoms of temporomandibular joint. She probably doesn't have a TMJ problem. Maybe she has arthritic disease of some sort, but she's got potentially a tumor, you know, and I've seen those patients. So I think it's important to get across to our listeners that every patient deserves a Panorex. They don't have to have a CBCT, just a Panorex. And if something looks different, then proceed on to more sophisticated imaging. And I think if that comes across today, that'll save somebody's life somewhere along the way.
Yeah, I agree with that, Lou. Orthopantomogram is a great screening tool. It'll show the majority of bad things, like tumors. I've seen a few, like you in your practice, where a diagnosis has been missed because there was no imaging. B-cell lymphomas, for example. Chondrosarcoma was missed. So I think some form of imaging in the form of simple OPG or Panorex, as we call it here in the States, that's a valuable screening tool and should be a starting point.
And Gary, is there any role of open joint procedures in Wilks 2 and 3 stage patients? What is your take on that?
So again, it boils down to this disc malposition really not being the primary problem. Lou mentioned it, I mentioned it in my presentation that in the 70s, 80s, it was considered to be the primary problem. Everyone was chasing this position of the disc, trying to put it back to where they thought it should be. Now we know that's not the case. My approach for disc repositioning, and as I mentioned, it's a very small number of patients because they have to meet certain criteria. The disc has got to be a normal shape. No point putting in a little fibrous ball back into position. It's not going to serve the role that it should. There should be no perforations. There has to be adequate joint space, because if there's not, and you squeeze the disc back into this narrow space, whether it's an open procedure or arthroscopic, you can't expect it to stay there. The pterygomasteric sling will win over your suture or anchor every time. So it's a very narrow indication, and the indication in my practice is function. Lou mentioned that mother of speed bumps, right? So if you have someone who's got a functional obstruction, a big loud click that's mechanically obstructed, sorry about the dogs barking, then yes, I would do a repositioning. Apologies for my guard dogs.
Not a problem, yeah. So, and to Dr. Vishal, what is your opinion? I mean, I think you mentioned about in your presentation about PRP and PRF in management of TMD.
Yeah, although we have a preliminary study, but in terms of joint noise and in terms of deviation of mouth opening, we found good result around 60 to 75% cases. But in terms of pain, it takes time, like around 3 to 6 months when patient become from VAS scale from A to 3. It took 3 months compared to the arthrocentesis, where arthrocentesis patient got relief after 2 to 3 weeks overall. So PRP definitely we found effective in case of joint noise elimination and correction of some more advanced stages of their deviation on the mouth opening. So that's why I'm starting one study where arthrocentesis plus PRP injections and followed by occlusal splint simultaneously. And I got getting good result in Wilkes stage 3 also.
Sir, what is the role of usage of IPRF, injectable PRF? Any experience with the
No,
injectable
I don't have
PRF?
any experience of IPRF, only PRP I have experience, and which because of IPRF is sometimes difficult to inject in blind arthros, conventional arthrocentesis after that. PRP is easy to inject.
is it good to use with the arthroscopy surgery?
I don't have experience. Gary will be the, or Niren will be the right person.
Professor Gary.
Yeah, so I think there are studies that show advantages and some studies that show no advantage. So that's the dilemma currently. I know Joe McCain is looking at PRP in his population of scope patients. I haven't done a formal study of it. In my experience of it, it's really not shown a huge difference in outcomes, I don't think. Not a significant difference at least. So I know Joe is looking at that currently.
Okay, any other panelist wants to add on this?
Yeah, I just reviewed a paper with a 5-year follow-up done again in the Czech Republic using PRP in patients with osteoarthritis. And if the patients had early stage osteoarthritis, they seemed to do pretty well. If they had late stage osteoarthritis, as you would expect, they didn't do very well. But the study was only 5 years and it was a very, very small number of patients. And I think that's been the experience in orthopedics as well. Early stage, if you treat early stage osteoarthritis, you get really good results, either with PRP or stem cells or whatever you want to use, even total joint replacement. If you do a knee with a stage 1 osteoarthritis, you get really good results. If you wait till it's stage 4 or late stage osteoarthritis, those patients don't do nearly as well. And we've seen the same thing with TMJ. If you take a late stage osteoarthritis patient, they don't do nearly as well as early stage, which makes us begin to think, you know, if you think the patient's going to end up needing a joint replacement, you might as well do it when you first see the patient, and you're going to get better results. And I understand the problems that you have in your country with joint replacement, although it appears in my discussions with some of the folks there that you do have some companies now that are working on developing joint replacement devices that hopefully will work for you.
Thank you, Professor. Aishwarya, you would like to add something?
No, I would like to ask a question for a change.
Please ask.
I want to ask Gary sir and all the seniors, any role of PRP in disc perforation?
Again, it's the same answer. I'm not sure with the current evidence.
But this doesn't heal. So how would that? What's the biology there?
So there is some literature where they say that once you do an arthroscopy and you see a small perforation, then injecting, instead of injecting steroid, it is superior to inject PRP into the joint in smaller perforations, is what I have read.
I haven't seen those.
That might be assumed that it might be healed. That's the only reason maybe. Because of regenerative property.
I think we have overshot the time by 30 minutes now. Professor Louis, what are the indications for TJR and extremes of age, young children and old adults? What will be your take on that?
The use of total joint replacement in skeletally immature patients? Is that your question?
Yes.
Well, I think Gary can probably answer that just as well as I can. We just published a paper in the International Journal showing some really good results in a fairly long-term study in these kids. And the whole thing comes down to Moss's functional matrix theory. If you get the mandible moving and the patient has a matrix, meaning they have a muscle matrix, they seem to want to grow. And if they don't, and we have another paper coming out in a plastics journal on skeletally mature patients with hemifacial microsomia. They don't grow, okay, because they don't have a matrix. So we're already starting to see that if you have a matrix, and so what we're talking about here are children who have an ankylosis, and you've tried 2 or 3 rib grafts and they all either ankylose or overgrow, which has been my experience. 56% of the patients who have rib grafts, they don't work. So why keep doing them? You know, and so why not go ahead with an alloplastic joint replacement? And the argument has always been, well, you know, you're going to have to do another operation later on in life. Well, you show me a patient you did a rib graft on, all right, that you never had to do another operation on, either an orthognathic procedure or some other procedure. So that whole argument that you got to do another procedure at some time doesn't hold water, in my opinion. So it's something that we're looking at. I think it's something that, you know, we got to think outside the box on. And maybe this is something we can offer patients instead of continually doing the same rib graft over and over and over again. You know, Einstein said doing the same thing over, expecting a different result is crazy. And that's been my opinion on that. So for skeletally immature kids that have a matrix, it seems to work in about 80% of the cases. In skeletally mature patients who do not have a matrix, like your hemifacial microsomia or any of the craniofacial anomaly cases, then, you know, it's probably a reasonable option for those patients. We have another study going on in our craniofacial unit where we're calling back a lot of the patients who had rib grafts or distraction osteogenesis to look at them and see what's happened to them. And it's interesting so far, you know, without a lot of data, that a lot of those kids did not do very well with autogenous tissue or with even distraction. And it's also telling that John Pauly, who was sort of the king of craniofacial surgery in Chicago, has completely gone to alloplastic replacement in his craniofacial cases. He's the one who invented the RED device. So yeah. he's come around. So anyway, that's a long answer. I apologize, but it's a tough question.
Can I,
Gary, Gary may have some.
Yeah, just a couple of comments. So the paper that Lou and I worked on with Steve Sullivan that's just got published, even what's interesting, even the unilateral cases where you would expect if there was no growth, then you'd develop facial asymmetry as they grew, that didn't happen. There was no reported cases of facial asymmetry developing. So the Moss's functional muscle matrix theory is what we think is behind all this. You got to realize one thing with considering alloplastic devices in children or skeletally immature people is that you're putting a joint in because the joint that they have isn't normal. So that joint isn't going to grow normally anyway. Worst scenario is you put the unilateral joint in or bilateral and you don't have the growth that you expect. That's not what seems to be the case based on this survey, but what would you do then? Well, it would be a simple case of revising just the ramal component. The second concern that everyone talks about is how long are these devices going to last? Because is that child going to have a reoperation? Like Lou said, the ribs, Great Ormond Street did a study 2 years ago, 10-year outcomes, and 50% of them had complications at 10 years. So a reoperation, it's possible, sure. But we know from our concepts, post-market surveillance and data that we're almost 30 years out now from using this device. And we haven't seen that pattern of wear and tear that you would expect to see with knee and hip prostheses. So it could well be that these devices do last, maybe even a lifetime. We can't say that yet. We just don't have that much data. So I think that the children thing in the US, we're bound by FDA limitations, and the alloplastic devices are not FDA approved for use in children. In India, may not be the case, so that's a good environment to look at that and do a more formal study of the growth implications and reoperation rates.
Yeah, that is a very good explanation. Thank you, Professor Louis and Gary. Fantastic. And I have a question actually. When Professor Louis finished his presentation, he said the the disc cannot be recaptured. And it's a question for Dr. Chetan Hegde. Do you think can recapture with a splint that you give the patient?
No, not really. What we're looking for with the disc is transiently, when the treatment has been going on, we give a splint to recapture the disc for the time being, well, as long as the splint is there inside the patient's mouth. But once the splint is removed, there is no way the disc is going to be recaptured. It is just that to relieve the pain, to relieve the pressure from the retrodiscal tissues, we give the splint and probably allowing tissues to heal, retrodiscal tissue to heal as well as to get fibrosed. Moment the splint is removed, the disc is on its own. So it doesn't really get removed.
So it is only an interim relief.
Can I comment on that?
Yes, yes, yes.
I think in literature, there's enough evidence that they say if it's a very acute disc displacement, which is most of the time we don't see patients with acute disc displacement, then I think the disc, the anterior positioning splint plays a little role in improving the joint space. And I don't know if it really recaptures, but it improves the position of the disc. But I think in chronic cases, we are only looking at creating a pseudo disc or just eliminating pain like Chetan was saying.
Thank you.
Yeah. Can I make a comment?
Yes.
Without getting into a long discussion, one of my pet peeves, there are two pet peeves with temporomandibular joint that I have, and both are words. The one word that really bothers me is the word splint. Okay, in orthopedics, a splint is used to hold bones together that are broken. All right. We use that term, and what we're talking about is really an orthotic, is to hold something in position, a movable part in position. So if you have fasciitis or something, you put an orthotic in your shoe. So what we're doing is really an orthotic. We're not using a splint. The splint holds broken pieces together. Nothing's broken in the term. So when we talk about using a splint in orthognathic surgery, that's the right use of that word, because we've broken the bones and we're holding the bones in position. But it is not a splint. It's an orthotic or oral appliance. So if we want to start talking about this joint orthopedically, we have to start using orthopedic terms. We have to stop using the wrong term. The other term, which I hate, is closed lock. Okay, that's a horrible term, and I won't get into that whole discussion. But those are two words that just drive me crazy when I hear them. Sorry.
Yeah, that's right. That's correct. I agree with you. That's a normal term which has been used for a long period of time.
Yes. It becomes normal. What I wanted to talk about that splints to your question, Dr. Jimson. When you use these orthotic appliances, okay, no, not splints, okay, orthotic appliances for the prescribed time, what happens is the retrodiscal tissues will undergo collagenization, and then there is a formation of what is called a neodisc. So it is almost equivalent to recapturing the disc. So that is how the patient has a permanent cure from the pain. That's what is the concept. The key is the orthotic appliance has to be used for the proper time. Yeah.
Thank you. Yeah. So I think there are a lot of questions. TMD never.
But I have one question to be asked to Professor Mercury, if you allow me.
Yes, Rich.
Yes, Professor Mercury. So you told me, you told all of us a new concept, that is the function of the disc is more important than the position of the disc. So, but in disc displacement without reduction, the disc is too much anteriorly placed, obstructing the translatory movement of the condyle. So in this situation, I think the position of the disc is important, isn't it? So do we ignore it here also, or you take it into account?
Well, as I mentioned, in those cases where after getting the disc moving, after an arthroscopic procedure, lysis and lavage, basically, if the patient continues to have problems directly related to the joint by the use, I can make that diagnosis by using a local anesthetic in the joint. I can relieve the patient's pain at that point. That's an indication for discectomy. Because that disc, if it's in the wrong position somewhere in the joint, it's creating this biomechanical instability.
Yes.
And further leading to more inflammation. More inflammation leads to more pain. More pain leads to more Hilton's law, decreased function, and that kind of thing. So, yeah, there are some patients that ultimately go on to discectomy. Those are the ones.
Okay.
Does that answer your question?
Yes. Yes, Professor. Thank you.
Vandana, you are muted.
We are running short of time. We will ask last 2 or 3 questions for this panel. One is for Professor Roy. What is the ideal method you will use for reconstruction of the disc? Sir, you are muted.
Sorry, my fault. My preference of method is the abdominal flat along with the abdominal as a combination of both. I've also used skin and fat from the iliac region also. Plus, we have used substitute of disc which we have taken on loan from the orthopedic surgeons as a study. When they do arthroplasty, they replace the disc with a PDS kind of material made of disc. So we used that, trimmed it and used it. But we have found the result best to be with the abdominal fat with the dermis area. That is my preference of choice for replacement of the disc.
How do you follow up those cases to look at the fate of the graft?
So what we do is that we have a protocol where we do the MRI immediately post-operatively after 6 months and after 1 year. After that, being in a particular service where we all move off after 2 to 3 years from a point, so their records are sent to the next place where they go, and they're in the same follow-up for 5 years. After that, no follow-up is done, unless they don't come back for specific problem again. That is the protocol which we follow here.
The last question for the panel to Professor Gary. Many young surgeons show great interest in acquiring the skill of arthroscopy. As your Indian study shows, around 85% of the surgeons are interested. And what would be your advice to be the beginner in learning this modality and putting into use?
Okay, so there are weekend courses that you can take. Our experience in the 1 weekend courses is that it really doesn't teach you to a level of competency. You need a more extensive training than that. In fact, the mini residency that we have here in the US, it's actually 4 3-day weekends. And it started off with a single weekend. The feedback that we got from all of the participants unanimously was that they didn't feel competent to go and do that on Monday morning. They needed more repetition. So then we did it 4 times a year. Unfortunately, this isn't a plug for the course, but that's the only course in the world that does that. We have the Amrita course that we have a basic and an advanced, so that's sort of middle ground. Hopefully that will be able to run again next year. This year it's been on hiatus because of COVID. And that's again a 3-day course with cadavers, emphasis on arthroscopy. So they're the real options for more comprehensive training that gives some repetition rather than just a single weekend course.
Yeah, thank you, Gary, for your response. So I think we have overshot our time, and the next speaker is waiting. Sanjay Pinto.
Sanjay.
Yeah. So thank you panelists for the wonderful discussion, wonderful presentations.
Yes, sir.
And I have a request. There are a few questions which are still not taken up, which are there in the Q&A. If I may request the panelists to just answer them, I think the participants will be really happy.
Yeah.
Yeah.
I am answering.
Yeah. So thank you. And we'll call.
Thank you
Over
all
to
the
Dr. Yes, Dr. Vandana. Yeah.
thank you all the panelists to enlighten us with the knowledge regarding how to manage the temporomandibular joint disorders. Thank you so much. We are running short of time. That's why otherwise we have a few more questions for discussion. It will be keep on going.
This
Now,
will keep on going if you keep on asking.
Thank you so much,
you
all of
have to-
you. I've got a small request, if it is possible.
Yes,
I
sir.
wanted to see who is Dr. Balaji, who is the talented maxillary
yeah.
surgeon. I actually want to see him. If he is there,
Balaji
can I
is
see
here
him?
on the
Dr.
panel.
Balaji, sir,
Balaji, can you-
please come on the video, please.
Hey, no problem. If he's not there, I'll contact him.
No, he's there.
subsequently.
He's there. You can
he's
see him
here.
on the screen.
Okay, I'm sorry, I can't see him. Maybe, Doctor.
Gallery view, go, sir.
I've gone to
Balaji,
gallery
unmute.
view also.
Unmute Balaji, say a few words.
Yeah, we can see him.
Balaji.
Okay, okay, okay.
Balaji.
Thank you so much.
Unmute
Thank you,
Balaji.
sir.
Balaji, you're on.
Thank
You're
you,
on
sir.
mute, Balaji.
Balaji, sir,
Yes.
you're.
Yeah. I think I was a little apprehensive while drawing Brigadier.
No, you are very talented.
In
Thank you
army,
so much.
And he had a gun. Yeah, he sent me a big picture of a gun also, separately. So I thought it should be a little, thank you very much.
Thank you so much.
I don't want to waste much time. Yeah.
Lovely caricatures, Balaji. Congrats.
Thank you.
So, yes. What is next, James? Jameson?
Can we sign off?
No. Please wait. There is another
Yes,
talk. Max talk.
Yeah. Sorry. My fault. Yes. Sorry.
That was a wonderful panel discussion, and I'm sure all of you agree with me. And I thank the moderators and the panelists for such an amazing and informative session. And now I request Dr. Jimson to introduce Dr. Sanjay Pinto, who will be talking to us about medical negligence and legal remedies. Over to you, sir.
Thank you. Just a minute, please. Yeah, Sanjay Pinto. I have great pleasure in introducing him. Before donning the black gown as an advocate in the Madras High Court, where he specializes in media, criminal, constitutional, and corporate arbitration and consumer cases, Sanjay Pinto was the resident editor of NDTV 24/7 and the executive editor of NDTV Hindu. A household name and the face of NDTV in South India for 15 years, Sanjay has reported breaking news developments from South India and anchored a slew of popular news bulletins and signature shows on NDTV. Sanjay wears many hats as a legal columnist of Deccan Chronicle with over 231 published legal columns till date, and columnist of Brits Magazine, a political analyst on national TV channel. May I request the others to mute, please. Channels, author of 3 best-selling books, My NDTV Days, Justice for All, and Speakers Are Made, Not Born, and the mentor of the Silver Tongue Academy resource that mentors youngsters in public speaking. This former national debating champion and gold medalist with a record 106 victories in intercollegiate debates representing Loyola College and the Dr. Ambedkar Government Law College is a recipient of Rotary Awards for his excellence in the media and law. And Sanjay has represented India in the IVLP program on the rule of law and judicial reforms in the USA in 2014 and is a guest lecturer on media law at national law schools in India. Welcome Sanjay to the program to speak on medical negligence and its legal implications. It's a pleasure to have you speak to our society. And this is again by Balaji. Thank you, Balaji. Here you go. Stage is yours, Sanjay.
Thank you, Dr. Jimson. Good evening to all the doctors there. I have great admiration for doctors. And I thank the Compare for giving me the honorary doctorate that I don't have. Perhaps it's a sign of things to come. Now, there were 3 doctor friends who were taking a stroll at the Marina Beach in Chennai early one morning. And they noticed a person walking towards them with a slight limp. So the first doctor surmised that it could probably be plantar fasciitis. The second doctor took a hard look and said, no, I think that's transient synovitis. And the third decided to guess. He said, look, to me, it looks like early stage arthritis. And they waited for the person to come closer. And before they could even open their mouth and ask him anything, the person asked the doctors, excuse me, can you tell me where the cobbler is? Because my slipper seems to have cut. Now, ladies and gentlemen, I'm sure many of you may have heard this rather interesting anecdote, but there is an underlying message. And the message is that diagnosis can be extremely tricky to even the best medical minds. A simple headache could be just migraine, or it could be a brain tumor. Ordering scans can lead to accusations of an unholy nexus with diagnostic centers, and haven't we heard enough of this already? Not ordering these tests, relying only on clinical examination, can be extremely dicey and fraught with legal risks. So see, either way, doctors are damned. Now, in my life, I have seen some absolutely brilliant doctors who inspire confidence in their patients. And I can definitely, in Chennai, name some of them. Dr. Biswa Kumar, eminent urologist. Dr. Nandakumar Sundaram, orthopedic surgeon. Dr. KP Suresh Kumar, cardiologist. Now, these are doctors who are bang on with their diagnosis. But obviously, that's a gift and that's a blessing. And not everyone may be endowed with that. So before I, delve into my presentation today, I want to cut to the chase right away. The big question that would be agitating a lot of us today is whether doctors are still under the new Consumer Protection Act 2019, which was only recently notified and came into effect from the month of July this year. The answer is yes, according to my interpretation. Please remember that the 1986 Act, when it first came into being, had section 210, which listed various services which came under its ambit. And of course, we know that the Supreme Court and IMA versus VP Shanta in 1995, after that, doctors were actually brought under the Consumer Protection Act. There was a lot of opposition. I remember being a student of law college then, going and speaking at a debate on this in the Madras Medical College, and we got a lot of people were booing us initially because we had to take a stand against the doctors in that debate, luck of the draw. But of course, that stayed. Now, if you look at the new act, the equivalent of section 210 is section 242, 2 clause 42, which has an inclusive list. Now, the devil is always in the details, and the devil in the detail here is not limited to. So a lot of people actually saw this list. They say, you shouldn't Google your symptoms. I would ask doctors also not to Google legal provisions and rely on lawyers to interpret it, jurists to interpret it, because what's mentioned here, while various categories have been mentioned in this appear, in my opinion, doctors are still under the Consumer Protection Act. There's no change from the earlier act and now. The other big question is whether this act will operate prospectively or retrospectively. Very recently, the president of the National Consumer Disputes Redressal Commission in New Delhi clarified, and that was put out on the website, that it will operate prospectively which means whatever cases you had earlier will stay and will stay where they are. Now, it's often a big toss-up, ladies and gentlemen. A patient battling for life and desperate family members rustling up all the money they can for a surgery versus a corporate hospital that insists on advance payment and legally vetted consent forms. Now, I'll come to consent forms later in my presentation. This does not seem like even Stevens, does it? Ever since doctors were brought under the ambit of the Consumer Protection Act, there has been a delicate balance that has had to be struck. On the one hand, as laid down by the Supreme Court in that landmark case of Dr. Kunal Saha, remember, a doctor himself who sued a hospital for the death of his wife. The Supreme Court said doctors are to be dealt with strictly if they are found to be negligent with patients who come to them pawning all their money with the hope to live a better life. Along with hospitals being vicariously liable as held by the Apex Court in V. Krishna Kumar versus State of Tamil Nadu. On the other hand, ladies and gentlemen, is a practical view that the Supreme Court took in Jacob Matthew versus State of Punjab in 2005. And the Supreme Court said, a surgeon with shaky hands under fear of legal action cannot perform a successful operation. And a quivering physician cannot administer the end dose of medicine to his patient. Now, this is a judgment. Of course, it pertains to a criminal case of Section 304 of the Indian Penal Code, 304A of the Indian Penal Code. And it's cited in many, many arguments in several courts, especially in the consumer courts. The rationale is that the greater the risk in the operation, the higher the chances of success, as opposed to lesser risk but higher chances of failure. Now, what really constitutes medical negligence is something that we'll have to actually grapple with. In my opinion, medical negligence involves, for instance, I'll give you a list, an inclusive list: amputating the wrong leg or arm, operating on the wrong eye, leaving forceps inside the abdomen, prescribing drugs with serious side effects without taking into consideration allergies and the physical condition of patients, contraindication of drugs, needless procedures, botching up a simple cataract operation, for instance, leading to blindness. These would be clear cases of medical negligence where the legal principle of res ipsa loquitur, the thing speaks for itself, would apply. But we know, and I would like to reassure doctors, that the majority of doctors are absolutely ethical. They are lifesavers. I take my hats off when it comes to such doctors. And we do know that no doctor would ever want his or her patient to suffer, much less to die on the operation table or in the hospital or clinic. The Supreme Court is a very significant judgment, and it's important that you make a note of some of these judgments, because to a large extent it would serve to sort of instill confidence in you, because I know a lot of doctors are very troubled by this Damocles sword of legal action. The Supreme Court in Martin F. D'Souza versus Mohammed Ishfaq had said, different doctors have different approaches, some more radical, some more conservative. All doctors cannot be fitted into a straight-jacketed formula and penalized for departing from that formula. So you go to, for instance, you come to lawyers and ask for an opinion. You go to 3 lawyers, you'll get 3 opinions. So just because a doctor deviates from a particular approach in treatment or in surgery, that does not constitute medical negligence. You have this assurance from the highest court of the land. Now, consumer courts, consumer fora, consist of primarily laymen in the field of medicine. Okay, they have to rely on medical opinions of experts from people like you, who many believe may be prejudiced. They say there is honor among thieves. It happens to in every profession. So it's very difficult actually to get one doctor to testify against another doctor. This is a practical reality. But will an error, and this applies, as I said, to every profession. It happens to custodial torture in police stations. It's very difficult to get the convictions because the police will not really let down their own. So will an error of judgment constitute medical negligence? I think this is a question that vexes most doctors. Will an error of judgment, an innocent error of judgment, constitute medical negligence? In my opinion, it would not. Today, please be reassured that at least in the National Consumer Disputes Redressal Commission, there is a medical doctor who sits on the bench for medical negligence cases. So it's not as if a layman is sitting and deciding over a complex medico-legal issue. You have Dr. S.M. Kantikar, a brilliant judge, who's sitting there as a present expert presiding officer for medical negligence cases in the highest consumer forum of the country. Now, what exactly constitutes medical negligence? If it's not misdiagnosis, if it's not error of judgment, we go by the Bolam test. What is this Bolam test? The Bolam test simply states that a professional need not possess the highest expertise. It will suffice if that professional exercises the ordinary skill of an ordinary competent person exercising that particular art. So it's that minimum, in simple layman's terms, it's a minimum standard of care that has to be determined. Now, with reference to the National Consumer Disputes Redressal Commission decision in Sarwat Ali Khan versus Professor Gogoi, there were certain broad guidelines that were framed by the courts, such as prescription of drugs only after actual examination of a patient, not on the telephone, cross-checking symptoms with tests and investigate diagnostic test results, not experimenting, not making patients guinea pigs, timely consultation with experts, like for instance, does a patient who has suffered a heart attack need angioplasty or an open heart surgery or CABG? So kindly consultation with experts, maintenance of records for diagnosis and treatment. Now again, I'd like to put many doctors at rest, because I know, see, a lot of these things which circulate today on the social media and WhatsApp, and I know a lot of my doctor friends have been asking me about this right from 2018 onwards. I in fact even wrote a column about it in the Deccan Chronicle. The Mumbai High Court in Pavaskar versus State of Maharashtra had actually, in the judgment, actually, it's not the High Court, but the judgment had led to various interpretations and triggered needless panic in medical circles. Many people believed and they misinterpreted that judgment. It was actually a judgment, an anticipatory bail. It suggested that many people thought that telephone consultation would make the doctor liable for prosecution under Section 304 of the Indian Penal Code. What is 304 of the IPC? Culpable homicide not amounting to murder. The context was completely different in this particular case. It was a finding, as I said, in an anticipatory bail plea of a doctor couple who had allegedly advised the patient with post-delivery complications not to go to another hospital, although they were away, and prescribed medicines on the phone to the chemist. This was the gist of that case. The patient, ladies and gentlemen, unfortunately died, and the police booked the doctors under Section 304 IPC. So clinical examination before prescribing drugs is the ideal practice. But please understand, and patients know it as well, as do the courts, that life is full of surprises and emergencies, and doctors cannot be omnipresent. Today during COVID, we are actually telling people do, teleconsultation, because it's not safe for people to go to hospitals, at least for those with serious comorbidities. If there's something that can be, handled on the telephone, that's great. And we are requesting, we are pleading with doctors to do this, and many doctors are obliging. So please be at rest. Telephone consultation cannot be criminalized. If it is, you can come to me. Telephone consultation may save lives, especially in cases where the patient cannot travel or where there is a delay in getting direct medical treatment. Now, let's face it, we've all seen, and I have witnessed it firsthand, even in the emergency wards of hospitals. Let's say somebody is admitted in the dead of night with a heart attack or some other emergency. The specialist is not available round the clock. There is a junior, reasonably experienced junior doctor who's there in the ER. But of course, you'll have billboards saying 24/7 emergency care and all that. The duty doctor would invariably WhatsApp or call the expert, let's say a cardiologist. They would WhatsApp the ECG report immediately, pulse and blood pressure readings and other parameters. and based on the telephonic advice, administer that first aid or shift the patient to the intensive care unit. This is a regular protocol that is being followed. So it's not as if telephone consultation is something new. It happens regularly, even in regular treatment in hospitals. Now, I will be brief because I know that you're running out of time and I don't want to stand in the way of your Sunday dinner. What can you do as a doctor? What can you do as a hospital administrator? I think that's something that you want to know, Sean, of all the legalese that I've given you. I've tried to make it as simple as possible for doctors to understand. For the doctors in hospitals, one, please come clean with records. It shows that you have nothing to hide. Do not fabricate things to try and escape any sort of legal liability, because let me tell you, that could backfire. That could backfire. Your antenna should go up the moment patients make a request, either the deceased patient's relatives or a discharged patient. They make a request for complete medical records, and under section 1.3.2 of the Code of Medical Ethics and Regulations of the Medical Council of India, you're aware that doctors and hospitals are bound to hand over medical records to the patient or relatives within 72 hours. Within 72 hours. Aside of this, please remember that today, this is the age of smartphones. Patients take immediately photos of everything. Every bill, everything is all stored and kept. So don't underestimate the patient. Come clean with records. Second, please do not fall back on consent form disclaimers. We know that consent forms, most things, even employment contracts, there are several things. The Law Commission in its 200 report has also spoken about this, about these unilateral standard form agreements. They are lopsided. They are signed hurriedly. I myself have signed them. You're literally, the patient is, or the attendant is literally standing on one leg, on one foot, because you have to remove your slippers or footwear and go into a particular cat lab or whatever, and then they give it to you, hold it against the wall and sign it. No question of even reading the fine print. Now, very interestingly, a couple of months ago, this is the latest judgment of the National Consumer Disputes Redressal Commission, the case of Vinod Khanna versus R.G. Stone Urology and Laparoscopy, 2020 judgment. The court, the commission found their pre-printed informed consent cum undertaking form to be unfair, one-sided, arbitrary, high-handed, and they said it was a violation of under unfair trade practice of the old Consumer Protection Act 1986 Act under section 21R. And you know what? They imposed a fine, a compensation of 10 lakh rupees on that hospital to be paid to the consumer forum. So don't fall back on these disclaimers. It's like taking an umbrella during a cyclone. Okay? It doesn't cover your tracks completely, only to a very limited extent. Now, pay attention to your paperwork. I told you earlier how patients keep records themselves. Keep copies yourself. You may leave the hospital and go to another hospital. And that hospital, then you may not have probably left, if you've left on not very cordial terms or slightly unceremonious. They may not oblige. They may not give you all the copies that you want, all the documents that you want. They may hold back something. Your junior doctors may turn hostile. There may be some misunderstanding. So make sure that for all your surgeries, that you have your own set of documents, you have your paperwork with you at your place. Keep them intact. I'm sure 99% of you do this, but I'm just flagging this because I know some of the best doctors sometimes lose out on these small things, and these are things that lawyers will look for, to actually nail you. MRI reports, for instance, you prescribe someone an MRI, go through the images and don't rely on the radiologist's impression. Make sure that the correct doctor's name is put there, the person who's referring. Now, this is very important. Whether it's a discharge summary or whether it's a death report, do not allow as a practice a junior doctor to sign for you. I know of cases, I'm in fact handling some cases where a junior doctor has signed for the senior doctor who was supposed to do a procedure. He was blissfully ignorant of what happened. They signed and they gave a particular reason as a cause of death, and that is still haunting that particular doctor. It's being agitated at the highest forum today. So don't make that mistake of, as a practice, you have to sign something, make sure you sign directly. Don't delegate that signing authority to anyone, because it can come back to bite you and bite you really hard. Insist as far as possible, if there is some death that has happened on the operation table or during treatment, that you feel could be challenged in court, insist always on a post-mortem. Come clean, call the police if required, don't hide anything. Now, what will happen at a practical level? Many families, many attendants of the deceased would plead with you, we don't want this post-mortem, we don't want, please, it affects this, sentiment is involved and all that. Fine, respect that, but get it in writing from them. Get it in writing from them that they don't want a post-mortem for whatever reason. Because tomorrow, there's a 2-year limitation period for a person to file a consumer complaint. Tomorrow, they will go back to the court and say, no, post-mortem was done, this was happened, that happened, and therefore the doctor will then, you can't go and tell the court, look, they didn't want it. Court doesn't rely on this oral testimony, he'll say, give us something in writing. So therefore, it's important to get it in writing if the attendants or the relatives of the deceased ask you not to have a post-mortem, they make a request, let them do it in writing. Be aware of your legal rights. Aside of the Consumer Protection Act, I'm sure you have, in medical college, they teach you, medical legal cases, but there is a difference between 304, which is culpable homicide not amounting to murder, which is a very rarely invoked provision for doctors, because people are aware, doctors try their best to save lives. As school children, when we grew up, I remember some of the things that I heard. Before a doctor goes into the operation theater, they would tell themselves, or they would tell the patient's relatives or the patient, I will do my best and let God do the rest. So there are certain things that are in their hands, and there are certain things that are not in their hands. The human body is so complex. If criminal action is to be taken against a doctor, aside of consumer action, case in the consumer court, please remember the Consumer Protection Act is a right that is not in derogation of any other remedy. So technically, you can have a criminal case plus a consumer case against a doctor for medical negligence. Both are possible. Now, 304A of the IPC, okay, this involves criminal liability that can be fastened on doctors. But this is another judgment that will come to your rescue. Jacob Matthew case. Jacob Matthew case is something that you should, take a printout and keep. Supreme Court had given detailed guidelines in this Jacob Matthew case and very clearly protected doctors against any possible police harassment. Because to convict a doctor in a criminal case, it must also be proved that the negligence was not just gross. First, you have to prove that it was gross negligence. You also have to prove that the doctor was reckless, that there was a clear case of recklessness of the doctor in that case. So these are some of the things that doctors and patients, doctors and hospitals need to keep in mind. Now, doctors can also be patients. Remember in that landmark case, Dr. Kunal Saha, his wife was a patient, his wife died. So for doctors, for patients, for families, these are some of the things that you need to keep in mind. The first step in proving medical negligence is collecting evidence. What is this evidence? Primarily, all the prescriptions, the discharge summary, the death certificate, test results, all these you need as a file. But as I told you earlier, under the medical ethics, the code of medical ethics, patients have a right to actually have a statutory right to get an entire set of the medical records within 72 hours from their asking for it. So this is actually a very patient-friendly legal measure. You can't really hide anything. Also, I'd like to tell doctors, your nurses' notes are very important. Please also instruct the people working for you that they need to be very accurate in their nurses' notes. As far as possible, try and make it as legible as possible. I know there's this joke about doctors' prescriptions and the handwriting and all that. Now most doctors are relying on printouts rather than handwritten ones. I have seen doctors who've got calligraphy, not handwriting, but some doctors what they call foul scratch. Make sure the nurses' notes are intact. In fact, nurses' notes have come in handy in a case that I know of where the patient left the hospital for a diagnostic test, didn't return after for 5 hours, he had vanished. But then fortunately, the nurse's notes reflected the timing. So it's important that the nurse's notes are comprehensive enough. That will help you at some point. The second aspect comes expert medical opinion. As I said earlier, it is not easy to get one doctor to testify against another. Like it is not easy to get one police officer to testify another against, get a lawyer to file a complaint against another lawyer before the bar council. This is a reality. But when, as a patient's relative, as somebody wants to file a case of negligence, when you need that medical expert opinion, pick a credible specialist, not a general practitioner. So let's say, for example, if you're dealing with the case of DVT, deep vein thrombosis, get a vascular surgeon or get a cardiac surgeon, get a maybe an orthopedician, somebody who's connected with that particular condition. Don't get a general practitioner. Don't get a general practitioner. A lot of people make this mistake and it goes against them. Thirdly, the claim for compensation. That is crucial to show credibility of the complainant. That claim for compensation, ladies and gentlemen, must be reasonable, because compensation should be a relief, not a bonanza. So let's say the age of the person is very crucial. How many years of life he had left? What were the earnings of that person at the time of death? What was his career trajectory like? What was his earning potential for the next or whatever years? If he's an employee of a company till the age of 60, there's a calculation to be done. Or if he's, let's say, a lawyer has no retirement age, a doctor has no retirement age. So for professionals like this, obviously the compensation can be pegged at a much higher level. The principle relied on by the Supreme Court in cases of compensation, especially in medical negligence, is in a landmark case, a seminal case of Malay Kumar Ganguly versus Sukumar Mukherjee. And that principle was restitutio in integrum, which means a person is entitled to damages and it should put him as nearly as possible to that same position as he would have been had this not happened, had he not sustained that wrong. So put him back in that original position. That is a principle broadly to be followed in a case of compensation. So, ladies and gentlemen, our courts have consistently come to the rescue of victims of medical negligence. There's no doubt about this. There are no two opinions about this. Our courts have awarded substantial compensation. But the higher judiciary, for instance, in the landmark Martin D'Souza case, has also recognized the possibility that, and I quote, even the best professionals, what to say of the average ones, sometimes have failures. But my appeal, in fact, as a takeaway from this webinar, my appeal to doctors, especially to the big corporate hospitals, is that you know if a case falls under the category of medical negligence or not. You would know, right? Your gut feel would tell you, your experience would tell you that. As far as possible, if you can, and if it's a genuine case of negligence, sympathize, show empathy with the patient, the family of the patient. If it's possible, doctors have a wide network to sponsor the education of the children. Plead with the hospital management to probably use their insurance to settle the matter amicably. It's good for all. There's no Damocles sword over you. And remember, adverse publicity that an adverse judgment in a consumer forum can affect the reputation of a doctor for which he or she would have slogged for decades on end. That's not something that you want. It's not fair to the doctor as well, because character assassination, which can happen today, you have to contend with the social media as well, can virtually finish off the career of any professional, not just doctors. So as far as possible, it's also the right thing for you to do. If you know that it's a genuine case of medical negligence, don't fight it. Try and make amends in whatever way you can. And at the end of the day, you are accountable to God as well as your conscience. So that is something I would make an appeal to all doctors whenever it's case. I know several cases where I have told doctors this, and some of them tell me, look, we don't mind, but then the hospital would say, look, we're setting a bad precedent. I don't think that would be a bad precedent. I don't think goodness, I don't think fairness, I don't think justice would ever be a bad precedent in this world. So as far as possible, do justice if you know it's a case. If it's not, fight to the finish. Fight to the finish, because you have your reputation to protect. And as I said at the very outset, most doctors, a majority of doctors, nobody wants the patient to suffer or die. So hold on to that. And at the end of the day, please understand that in our world where doctors are worshipped, are treated like God by their patients, their responsibilities also is sky high. Your Hippocratic oath cannot be reduced to a hypocritical oath. That's something that we should always keep in mind. But at the same time, the law must only be a watchdog. The law must not be a bloodhound. Thank you.
Thank you, Sanjay, for the wonderful presentation. We have time for two questions. There are a couple of questions that have been asked. One question is that in most government hospitals with a high footfall, it becomes quite impossible to keep copies of all the documents. So how do you defend in such situations in a government hospital?
You mean for the individual doctors or for the hospital as such?
Yeah, I mean, actually, I think the hospital, the individual doctors will be penalized, right, in such situations.
See, what happens in most of these cases, there are a number of respondents, what they call opposite parties in a consumer case. So it will be the hospital, it will be the individual treating doctors, the seniors and the juniors as well will be named in the complaint. That's a tricky situation because I know that a lot of red tape involved there, and it's better actually for you to keep copies because later on to get copies to defend yourself. Let's say, as I told you, you leave that government hospital, you don't have access. You don't have access there, and you'll be hit by bureaucratic red tapeism. So in such cases, and for the government hospital, I mean, okay, a government hospital reputation is one thing, but an individual doctor's reputation, I would say, is more precious. That's more precious. So therefore, I think today you have smartphones and you take your phones everywhere. I think whenever possible, at least the key documents, the important documents, just take a screenshot immediately. So many of us take selfies. We take selfies of virtually everything in our life today and put it up on social media. Do this to save yourselves. Take a screenshot at least of key documents and keep it in your phone. Mail it to yourself if you're the question of email storage on your phone later on. Just mail it to yourself later and leave it. It will come in handy at some point. Okay? That's my advice.
Thank you. There's one more question. Is it legal to air surgeries from an operation theater? That is live demonstration of surgeries to our own colleagues within the hospital setting.
See, this is always a very dicey issue. But then we know that medical research calls for there are certain requirements for medical research. I would say in such cases, it's always safer to get the consent of the patient, specific consent. Don't just have a general consent, and the general consent includes recording of surgery procedures and all that. Because now, especially after the Justice Kutusami judgment of the Supreme Court, privacy is now a fundamental right. And there could be nothing more private than somebody's body at a time when he or she is subject to anesthesia and doesn't know what's happening. And then you go and record and you put that, although you may blur the face and all that, at the end of the day, sometimes things can leak out. So get specific consent of the patient and the patient's attendant relative that this is okay. And once you do that, I think you're legally well covered. There shouldn't be any problem with it.
Okay.
I have a small question for Mr. Peter.
Yes, please, Doctor.
This is an amazing talk you gave.
Thank you, Doctor.
I just wanted to ask you, a couple of years back, there was one individual who died in All India Institute of Medical Sciences when a Japanese doctor who had come here to do a liver transplant for him, who is supposed to be a pioneer in that particular surgery. But due to whatever reason, it may happen in any surgical procedure. So I think so the Medical Council of India, followed by our Dental Council of India, gave a dictum that there will be no live demonstrations. And the organization where I work, we got the dictum that there will be no live demonstrations and you can record it and take consent of the individual. And if the individual gives consent, then only you can project it in a place where it is only same specialty people are there. So how does this legally stand actually, this thing?
I think they're being extremely cautious. They're being very cautious with that approach. But as I said, you can take the consent before a procedure itself, specific consent, doctor, that we have no issues, we have no problem, we consent to the procedure being recorded. Take for instance, this particular, I'm glad you asked this question. You go to a dentist today, you go to not just a dental surgeon, but you go to any general dentist, and they will show you, for instance, if you need braces, they will show you pictures, tight close-ups of people's teeth and before and after. Right, this before and after. And I remember once asking the dentist, I mean, this person's teeth before, have you got her consent? I said, yeah, you got her consent, all that I've taken care of. So that could be dicey. So nobody wants to see, everybody would like to see themselves in the best possible light. You show someone's crooked teeth and a lot of gaps and all that, and then they can actually sue you for defamation, right? So it's always better to take consent before you do something. If you can take it after as well, that's okay. But as I said, medical research calls, there are certain requirements for medical research for the overall benefit of society. A doctor is not going to take a recording of a procedure to show off and to put it on Facebook and all that. He's doing it the larger public interest in mind. And to serve that larger public interest, I think these things are required. But at the same time, you need to protect the privacy of the patients involved, and for that, you take their consent and take other precautions like not revealing their identity as far as is not required, not showing the face and all that. Those are things which can be used. Those are legal safeguards that you could additionally take, apart from getting the consent.
Thank you.
Welcome, Doctor.
Nice to see Dr. George here.
Is it me?
Yes, sir.
Yeah. Sanjay, my name is George Paul.
Good evening, Doctor.
Good evening. I'm a maxillofacial surgeon like all the people who are here. As you can see, I'm probably a decade older than you. And the last couple of decades, I have really missed you and Jennifer Roll on NDTV. I was a big fan of, I still am a big fan of NDTV.
Thank you, Doctor.
I also happen to be a lawyer by qualification. I also have a post-graduation in medical law. I've written a book. I must first compliment you on your lovely talk.
Thank
because
you.
managed to get a whole lot of issues in the small time that you were offered. And I think it was extremely clear, very lucid.
Thank you,
I'd like to make a few comments. Can I take about 3 minutes to do that, Jimson? Is that okay?
Yes, sir. Yes, sir. Yes, sir.
I'm not going to ask a question. I'm just making some comments. Is that okay with you, Sanjay?
Yes, Doctor. Absolutely.
Yeah. Some of the comments that you made, because I actually have, I do consult a lot. Not, I'm not an advocate. I'm a lawyer. So people ask me all the time about things, and I appear as an expert witness in the court very often. So I just thought I'll just first I'll.
That's going to be a great resource for me as well. And I would like to correct you. I don't think it is very evident that you're much older than me. I can also see a treadmill in the background, and that explains why.
Yeah, well, as a former journalist, you will notice all kinds of things, isn't it? Be careful. So Sanjay, I just wanted to talk about two things that came up as questions. One was the government doctors. Government doctors are not covered by the Consumer Protection Act, as probably everybody knows. So they come under contract of service. So technically the government is responsible. So they really don't have to worry so much. If any kind of a shortfall comes, it's basically the government's responsibility.
Okay. Just to slip in something here, I mean, in that IMA versus VP Shanta case, this aspect was addressed where if you don't pay, because government hospitals usually are free, the treatment is free. Consumer Protection Act says there has to be consideration. But the court also ruled that as long as there are patients in that hospital who also pay for the service, then the hospital can also be looped in a consumer case. Just a small
but most for practical purposes, all government hospitals are considered to be outside the ambit of.
Yes. Otherwise, we'll have a flood of cases.
We'll have a flood of cases, and their contract is basically they're getting a salary. So it's a contract of service and not a contract for service. So you know the definition of service doesn't actually apply to them. But there's a counter argument saying that if you are receiving a salary, you are receiving money from the taxpayer, and therefore there is a contract technically, but I think it's not really been addressed very well. And the other thing I think you rightly said, confidentiality is the issue. The two questions that came up, as long as you have a written disclaimer saying that the patient has allowed you to use their photograph or whatever it is, I think it's perfectly all right. I just wanted to say 3 or 4 things that you had addressed very comprehensively, very nicely, and I think you're the first lawyer I've seen who has really understood the medical part of it very well in the process of trying to address this thing. And it was fascinating. In fact, on 20th of September, I'm giving a talk for the Dental Council of India on informed consent. And I'll invite you. I'll send you.
Look forward to that.
Yes. One was your interpretation of the Consumer Protection Act was perfect. a lot of doctors, I'd seen all these WhatsApps that had come out saying that they are exempted. And I think I was one of the first people in the country to actually come out and say, you guys are fooled. And I quoted exactly what he said, not limited to was the operative line which made the difference. And teleconferencing in the present times, I think, has been waived as being acceptable, although a few months back, teleconferencing was frowned upon by the Supreme Court. So I think these are difficult times, and I think you balance that issue very well. I just wanted to mention that the Bolam test is now, I made a few notes as you spoke, the Bolam test is now actually replaced by a Bolito test. I don't know whether you've heard about it. There's a test called the Bolito test.
No, I've not heard of that.
Okay, the Bolito test actually doesn't, if two people have different opinions, you still have the onus of proving that lies with having to bring in evidence-based medicine to prove that both of them are right. You can't just say, just because two great people have said two different things, doesn't mean that both of them can be right. Like, for example, CABG or a stent to be put in. And if the majority of evidence-based points that one is not really acceptable at this point of time, that is accepted. So it's a small variation from the Bolam test. But the Bolito test is being used more frequently in the Western countries. I think it's been used in India as well in a few cases. You listed a number of negligence issues which were very, very appropriate. Very interestingly, the res ipsa loquitur thing is when you leave behind an instrument in the abdomen or somewhere else. That is one thing that is thing. But the res ipsa loquitur is mostly used in the consumer protection codes. It's not used so much in the civil codes, because there are some things that you actually leave behind purposefully. And just to get over that thing. That was a very nice point you made there as well. The new amendments have changed the pecuniary jurisdiction. I think the people here should know. Now, up to 1 crore can be decided by district court.
Make that clear to them. Earlier, it was up to 20 lakh in the district forum.
Yeah.
From 20 lakh to 1 crore in the state commission, above 1 crore in the national commission. Now they have made it up to 1 crore, and the district forum will now be called district commission. Up to 1 crore in the district commission, up to 10 crore in the state commission. That is 1 crore to 10 crore in the state commission, above 10 crore in the national commission. How this will benefit doctors? I'm glad you mentioned this. How this will benefit doctors?
It's not going to benefit doctors. It's going to be terrible for doctors. It's going to be terrible for doctors.
No, I'll tell you how. I'll tell you how. Because a doctor, let's say most medical negligence cases would be up to 1 crore or 1 crore up to 10 crore. Most cases would be within 10 crore. Now, that will be in the state of, like for instance, if there's a hospital in Chennai, it's going to be only in Tamil Nadu, it will be in Chennai. So a doctor doesn't have to necessarily go to Delhi, doesn't have to engage a lawyer in Delhi. By and large, at least in the first instance, it's going to be there. But it will, within here, it's earlier up to 1 crore you have to go. Earlier up to 1 crore you have to go to, above 1 crore you have to go to Delhi. Now for up to 1 crore you can do it in your district commission.
Absolutely.
That will go against doctors.
It's going to go against doctors. So they need to be aware that litigation is going to really go up. It's already gone up. Even during the Bolam time, I'm getting so many letters of cases which, now that I know that you are in the High Court, and after hearing you, I think I can send some of them over to you if it, if it needs to go. The pecuniary jurisdiction is very important, and most doctors have missed it. They don't realize that they are in a worse off situation than they were a couple of months ago. The documentation, as I said, is very, very important. And the informed consent document has become such a painful business today that you actually need videography of you talking to the patient. Even the writing, even a holographic informed consent is not acceptable now. They're actually looking at videography, especially in research informed consents. So I think people have to be much, much more careful. And in the same vein, you also mentioned the several negligence issues. One of the negligence issues that you didn't mention, but I thought which is relevant, is some things happen quite often. Like, for example, if you're removing a last molar, you can get a numbness of the lip. Now that happens in about 5 to 10 cases, and which is okay. But if you don't mention in your informed consent that it can happen, then it becomes a negligence. So, just another thing that you need to add to the issue of negligence. And the post-mortem issue, it's something that I come across very often because I do a lot of cancer work. I used to do a lot of cancer work. So everybody says we don't want a post-mortem and things like that when people die. Not many people die in a dentist's hand, but because I was a surgeon who was doing cancer. Now, the problem here is that it's not the death certificate that doctors actually give. It's actually the MCCD. It's called the medical cause of death, medical certificate for the cause of death. So a lot of people think the death certificate is given by a doctor. Death certificate is given by the municipality or corporation. It's the medical certificate for the cause of death. And a lot of people are hesitant about giving. Even yesterday, I called somebody in Calcutta who called me and said, you can go ahead and give the cause if you know what it is. If you do not know the cause, then it definitely calls for a postmortem. So the best thing to do if the patient is arguing with you is to actually hand over the case to the police yourself. And they can deal with the police and say they don't want a postmortem, they want a postmortem. So you can actually relieve yourself from the legal issue of handling that part of it. The 304 is never used in our situation. It's always 304A. But if you are drunk and you do not have a license, and if you have exceeded the mandate of what you can do, then the 304 can actually be implemented.
I think in that Bombay case, 304 was used, doctor, and they finally got anticipatory bail from the Supreme Court.
Sanjay Dutt case, isn't it? It should normally have been a 304A, but then it...
No. This was the Pavaskar.
Okay, I was talking...
Pavaskar case, 304. Yeah, they used 304. They got anticipatory bail from the Supreme Court finally. Because there they said, doing something with the knowledge that is likely to cause death. So that
it's a matter of interpretation.
Yeah, it is very, very. I agree with you. Seldom is it used. Very, very, very rarely invoked.
Rarely it's used. But I know doctors need to be warned that if they're drunk, they don't have a license, or if they have done something that they're not supposed to do, and if that is pointed out, then it can become a 304 rather than a 304A. Because 304A is bailable, 304 is not bailable. So, that's a big difference, which means they can lock you up. And 304A, they don't lock you up. Very nice. Finally, my last one, Jacob Matthew case. I know that case quite intimately. Markandeya Kadju, I think, gave the verdict. I think he was the head of the 3-judge bench which gave that case. It's a big boon, and I actually, like you, I would encourage every one of them to take a copy and keep it, because still the police do not know, and they still arrest doctors, unfortunately. So if they can at least tell them there's a Supreme Court order saying you cannot, you can arrest them, but you can't detain them. And only a medical board can actually give a decision on whether there was a negligence. And the Martin D'Souza case also, as a civil case, came out that you can give, you need a medical board to give a decision. But what has happened now is that it was overturned. I think it was in 2013 that the Martin D'Souza case came. I think in 14 or 15, they overturned that case. So now you don't need a medical board in a civil case, but in a criminal case, you still need a medical board opinion. That's it. I just made a few points as you spoke, so I thought I'd just
very useful. Thank you, doctor.
Sanjay, and
thank you.
It was very nice. I was very impressed by the fact that you were able to cover so much in the language that doctors understand. Most of the time, lawyers speak language that they don't understand.
Thank you, doctor. Thank you so much.
Thank you, sir, for coming and commenting about and give
my pleasure. I would never have had an opportunity to speak to this guy. This guy was my fan, Sanjay. I'm sorry, I was his fan.
Thank you.
I always used to watch NDTV, and really like you and Jennifer, and of course Sam Daniel as well. Yeah.
Thank you. Thank you, doctor.
Thank you, Sanjay. And 1 minute, I'll just I was trying to hand over the certificate of participation. I know you're not in person, so I thought I'll share the screen and then He'll send the certificates by mail, first to Professor Louis Mercury, Dr. Gary Warburton, Brigadier S.K. Roy Chowdhury. Thank you all. Dr. Chetan Hegde, Dr. Nehal Patel, Dr. Vishal Bansal, Dr. Aishwarya Nair, Dr. Vandana Shenoy, and Sanjay Pinto. Thank you again. I'll share the certificate with you, and it is really a pleasure having you with us. Thank you, Sanjay.
Thank you very much, Dr. Jimson.
Thank you, Dr. Jimson.
Yeah, yes, sir. Just
Thank you, Jimson, sir.
And I'll take your leave.
Dr. Melita.
Yeah, yes, yes.
Yeah.
Now for the closing remarks. Thank you all for the very patient listening. I'm sure 4 hours of continuous knowledge comprehending must have not been easy at all. A simple thank you will not suffice to acknowledge every faculty who took their valuable time to enlighten us with their expertise in this time-specific oriented program. We thank all our national as well as international participants who joined us all the way from Australia, Sri Lanka, Iran, UK, Indonesia, and Malaysia, to name a few. We would also like to applaud the untiring efforts put forth by Striker, Honorable Secretary Dr. Jimson, Honorable President of State Dr. Reena Ma'am, Dr. Balaji for the amazing caricatures, and the entire team of AOMSI, Tamil Nadu, and Puducherry branch, without whose contribution this comprehensive TMJ Web Conference would have not been a smash hit success. We kindly request all our participants to extend their undaunted support as always in the future endeavors of AOMSI, Tamil Nadu, and Puducherry branch to be continued in the following month. Stay tuned for next month. Topics on oncology and reconstruction, fantastic speakers, tips and tricks from the masters themselves, plus a lot of other surprises galore. This information is for our fresh surgeon passouts of 2020. Kindly upgrade your membership status from student life member to life member in the AOMSI website. For those who haven't registered as student life member until now, kindly register yourself as life member directly. The feedback link has been posted in the chat box. You can fill it to receive your e-certificates. That being said, wish you all an eventful week. Stay safe until next time. Vanakkam, Arios, Shao, Sayonara, bye and good night.
Thank you.
Tim, thank you very much. Reena ma'am.
Thank you. Thank you.
Everyone
Thank
for
you,
the
sir.
opportunity.
Thank you. Thank you so
This
much.
was wonderful.
Thank
Thank
you
you,
all.
Melita.
Thank you.
Thank
Good night
you.
and bye-bye.
Bye.
Thank you
Good
so
night.
much. Bye.
Link for
Good night.
feedback.
Good night, ma'am. Bye-bye.
Thank you, Dr. Chowdhury. Thank you so much. Thank you, Dr. Aishwarya.
Thank you, ma'am. Thank you so much.
Thank
Good
you
night.
so much. That was fantastic. Fantastic. Thank you, Vandana. Thank you
Thank you,
so
ma'am.
much.
Good night, ma'am.
Good night, Dr. Vishal. Thank you so much.